Hi everybody, and welcome once again to one of my USMLE Step 2 CK High Yield audio lecture review series. This is all information that I've taken directly from UWorld and put in my own words and arranged it in my own sequence here. In this lecture, we're going to be discussing the subject of rheumatology and orthopedics, as well as sports medicine. This is a great learning tool for passive learning. It's great for being in the car, at the gym, in traffic, or whatnot. And I just want to have this made available for you guys. And I thank all of you for your support and all your likes and comments and helping me direct which way to go in my next video. So thanks to all of you, and I always wish the best for each and every one of you, and again, thanks for everything. This is just for you guys, okay? So I know I wish I had something like this for myself, but anyway, so rheumatology and orthopedics with sports medicine. So let's divide the topic of range of motion. So you have in general statements, we have active range of motion and we have passive range of motion. And under active range of motion, that means that you're basically moving yourself, right? If you're able to move yourself, this is active range of motion. Whereas passive range of motion is when someone else moves for you, or when somebody else moves you. So that's the difference between active and passive ranges of motion. All right, simple little quick thing there. Moving on, we have joint fluid characteristics. So this is a nice little table from UWorld that explains all the different types of the appearances and what you see in joint fluid. So the appearance normally is clear. Joint fluid is normally clear and it has very low white blood cell count, less than 200, and less than 25% neutrophils. When you have non-inflammatory joint fluid characteristics like osteoarthritis, this could be also clear in appearance, and it can also have a white blood cell count between 200 to 2000. So the white blood cell count increases when there's a non-inflammatory state, and the polymorphonuclears, or the neutrophils, are going to be about 25%. Now when you have inflammatory diseases, this joint fluid characteristics will then go into transitioning between clear to now translucent or opaque. There's about 2,000 to 100,000 white blood cell counts in inflammatory conditions like crystals and rheumatoid arthritis. And there's going to be many neutrophils. Often there's going to be greater than 50%. And the septic joint is your next one. That's the worst outcome. Here the appearance is going to be opaque. The white blood cell count is going to be between 50,000 to 150,000, and the neutrophil count is going to be 80 to 90%. So normal, everything's clear, hardly anything in there, and as we go in from non-inflammatory, inflammatory, all the way to septic, the clearness starts becoming translucent, finally opaque in a septic joint, the most amount of white blood cells and the most amount of neutrophils. All right. So next up is hand and wrist pain. So the first topic with hand and wrist pain, you have carpal tunnel syndrome. So in carpal tunnel syndrome, the risk factors here would be like obesity, pregnancy, diabetes, hypothyroidism, and rheumatoid arthritis. Clinically, carpal tunnel syndrome is going to present with pain and paresthesias in the median nerve, and that distribution is between the first 3.5 digits. The symptoms usually are worse at night. That's something to remember. It's the median nerve, and it's usually worse at night. Clinically, the presentation is going to be a positive Fallon test and the Tinel test. Those are different maneuvers for diagnosing carpal tunnel syndrome. Then you have severe diseases where you're going to present with weakness of the thumb abduction and opposition, and there's going to be atrophy of the thenar eminence when it's all severe. The confirmatory test for carpal tunnel syndrome is going to be a nerve conduction series, right? So the nerve conduction study, if the diagnosis is uncertain or the symptoms are really severe, to the point that you're going to require surgery, this is going to show a slowing down of that median nerve conduction at the wrist. So when you see that slow nerve conduction, you might need surgical decompression or something. So the treatment, wrist splinting, so you kind of want to stabilize that joint. Wrist splinting, also steroid injection, and surgery, obviously, for severe or refractory symptoms. Carpal tunnel is going to be made of the carpal bones and the transverse carpal ligament, which contains the median nerve and the tendons of the flexor digitorum profundus, also the flexor digitorum superficialis and the flexor pollicis longus. So all the flexors, right? An electromyograph, that's usually not done in cases with carpal tunnel syndrome, and it's rarely done to exclude other causes or in patients with weakness or severe cases. So electromyography usually is not going to be the answer. A nocturnal wrist splint, that's going to hold the wrist in a neutral position, and what that does, it prevents excessive flexion of the hand during night, because remember, the pain occurs greater at night. Tenosynovitis. This is something that they really like to ask, and it's just basically you trying to put a name to this diagnosis, right? So it's an easy scenario. It's a new mother who's having pain when she picks up her kid, her newborn child or whatever, or the caretaker that's constantly picking up a child. So this is de Quervain's tenosynovitis, right? So most commonly occurs in mothers who pick up their child with the thumb that's outstretched or abducted and extended. And the cause is that it causes inflammation of the abductor pollicis longus and the extensor pollicis brevis tendons as they pass through that fibrous sheath at the radial styloid process. On physical exam, there's going to be tenderness that can be elicited when you directly palpate the radial side of the wrist and at the base of the hand. So there's a specific test called the Finkelstein test that while you passively stretch the affected tendons, you do that by grasping a flexed thumb in the palm with the fingers, and by doing so, you elicit the pain that way. So if they just say somebody that has pain in their thumbs and it's just because they've been picking up their child lately, or maybe they don't even say that, they'll just say that she's a new mother or a caretaker and constantly has to pick up a child, and that's de Quervain's tenosynovitis. There's also trigger thumb, and trigger thumb is pain over the palmar aspect of the first metacarpophalangeal joint, and it locks the thumb in a flexed position. And because it's locked in there, it's like a trigger thumb. It looks like a trigger. They like to ask that as a differential. So just remember, if they have a locking of the thumb in a flexed position, that's a trigger thumb, versus just pain with moving your thumb, that's de Quervain's tenosynovitis. And then finally, you have flexor carpi radialis tenosynovitis, but that's not specifically your thumb. That's more like your wrist. That's when you have radial flexion of the wrist causing pain, as well as point tenderness of the trapezium bone there. So when you flex towards the wrist, the pain is when you elicit flexion towards the wrist, you get point tenderness around the trapezium. That's flexor carpi radialis tenosynovitis. So it's kind of telling you right there. Flexor, pain with flexion, specifically towards the radialis from one of the carpal bones, so the trapezium. All right. Next up, we have elbow pains, and there's a couple of causes of elbow pain. The two main ones are going to be the lateral epicondylitis, or your tennis elbow, and then you have your medial epicondylitis, which is your golfer's elbow, and the other two are radial tunnel syndrome as well as Panner's disease. So let's start with the most common ones first. So lateral epicondylitis, or tennis elbow, this is caused by a repetitive contraction of the extensor muscles at the lateral epicondyle in any kind of activity like tennis that requires repetitive forceful wrist extension and supination, so like a backhand stroke in a tennis player, or somebody who's been using a screwdriver for a very long time. If you've ever used a screwdriver to assemble something and you've just been going at it because you don't have an electric screwdriver, it's all manual, at the end you're going to have some kind of pain there in that in your elbow, maybe, hopefully not. So chronic use of a screwdriver or a backhand in tennis, think of lateral epicondylitis. There's tenderness that's positive just distal to the lateral epicondyle, and obviously it gets worse when you use it. Pain is elicited by passive wrist flexion and resisted wrist extension and supination. And the pathophysiology here is obviously a degeneration of the tendon at the extensor carpi radialis brevis that's near the lateral epicondyle. So the way I remember this is lateral, you kind of have to, in order to do a serve in tennis, not so much a backhand, just for purposes of memorizing it. When you're when you're doing a serve for in tennis, you kind of have to swing forward, right? And to swing forward, you got to swing your arm laterally. And because of that, I think of lateral swing with a tennis player, lateral epicondylitis. I know it's dumb, but it's just the way I remember it. And then the opposite would be medial epicondylitis. So if you remember, medial would be your golfer's elbow, because you're swinging medially, like towards your body. So think of somebody who's putting in a golf course, and you're just putting, you're swinging softly towards the middle of your body, medial epicondylitis. So that's tenderness over the medial epicondyle, and the pain is elicited by by a resisted wrist flexion, and as well as a passive wrist extension. Okay, next up we have radial tunnel syndrome, and that's similar to lateral epicondylitis. It can occur in conjunction with that condition, so it could also happen with lateral epicondylitis, the radial tunnel syndrome. And here you have tenderness over the extensor tendon wad. On examination, there's going to be pain on flexion of the patient's long finger while the patient actively extends its fingers and wrists. So that's radial tunnel syndrome. And then finally, Panner's disease is the least common one here. This is osteochondrosis of the capitellum, and that typically is in adolescents who are actively involved in sports that involve some kind of throwing, like think of a pitcher or whatever. And it's a common complaint is a chronic dull pain causing crepitation and loss of supination and pronation. So they might throw you somebody there with a throw. They might throw you a question there with a pitcher, right? Somebody who's has to be throwing a lot. All right, so that's Panner's disease. It's chronic pain, crepitation, and loss of supination and pronation. And that's osteochondrosis of the capitellum. All right, doubt they're going to ask that, but whatever. Now we're going to talk about common causes of shoulder pain. So obviously, if you haven't done so already, which I'm pretty sure you guys have, is to try to memorize the anatomy of the shoulder joint. It's pretty easy. You have your clavicle and your acromion, followed by a joint in between the acromion and the clavicle. That's your acromioclavicular joint. And then in your acromion laterally, that's where your deltoid muscle inserts. And then underneath that deltoid muscle, you have a subdeltoid bursa. And then underneath that bursa, you have the supraspinatus tendon. So just to give you a kind of a view of what we're trying to work with here. So there's a nice picture on UWorld, or you can just look it up. It's the rotator cuff. So common causes of shoulder pain would be like rotator cuff impingement or tendinopathy. There can also be rotator cuff tears. There's adhesive capsulitis or your frozen shoulder. Also biceps tendonitis or bicep rupture, and finally glenohumeral osteoarthritis, right? So in a rotator cuff impingement or tendinopathy, the rotator cuff impingement is going to cause pain with abduction and external rotation. There's also going to be subacromial tenderness, and the range of motion here is going to be normal, but there's going to be a positive impingement test, and that positive impingement test is called your Neer test or your Hawkins test. Now, remember that rotator cuff impingement is going to cause pain when you try to abduct or externally rotate, but there is going to be normal range of motion with rotator cuff impingement. When you have rotator cuff tear, that's going to also produce pain, but the pain is going to be more weakness with external rotation. So again, you're able to move the rotator cuff, but it presents at a different time frame. So for instance, in a rotator cuff tear, the problem happens when you're older than 40, versus rotator cuff impingement can happen at any time. So they're just going to tell you more or less somebody who's older than 40 for rotator cuff tear, and impingement could be anyone really. Moving on, we have adhesive capsulitis or your frozen shoulder. Now, this causes decreased passive and active ranges of motion, and here you're going to have more stiffness than pain. So one thing I'd like to point out here is that rotator cuff tears and rotator cuff impingements, these are both going to cause pain, but the range of motion is going to be normal. However, in adhesive capsulitis, here is a frozen shoulder. There's no pain, but there's no range of motion. So it's frozen, right? Kind of remember that. Obviously it's frozen. Obviously there's going to be no range of motion. But what's important is that you're going to not have as much pain as you would in impingement or rotator cuff tear. For biceps tendinopathy rupture, this is an anterior shoulder pain. The pain happens when you're lifting, carrying, or reaching overhead. And weakness is also less common. Here, for the biceps tendinopathy, just think of somebody who's lifting, carrying, or something overhead, reaching for something overhead. For glenohumeral osteoarthritis, this is uncommon and it usually is caused by a trauma. It's a gradual onset kind of thing of the anterior or the deep, that causes anterior or deep shoulder pain. There's also decreased active and passive abduction, as well as external rotations decreased as well. That's your glenohumeral osteoarthritis. So let's go through these a little bit more in detail. The rotator cuff impingement or tendinopathy. This occurs due to a repetitive activity above the shoulders. It's common in middle-aged or older individuals. It also causes chronic tensile loading and compression by the surrounding structures. Because you have those, that's happening, this will lead to micro tears in the rotator cuff tendons, especially the supraspinatus tendon. And then that will then lead to a fibrosis and inflammation, as well as calcification. Pain can also originate from the subacromial bursa or the long head of the biceps, other than the rotator cuff tendons. Flexion or abduction will then cause a decrease in the space between the humeral head and the acromion, and that leads to a pressure on the supraspinatus tendon as well as the subacromial bursa. This will then lead to a compression of the soft tissues, causing an impingement syndrome. So then what you should do is a Neer's test, where you have the patient's shoulder internally rotated and the forearm pronated. And the examiner is going to stabilize the scapula and is going to flex the humerus. And if you reproduce the pain, then it's a positive test. Now, a chronically untreated rotator cuff tendinopathy increases the risk for a tear, and a weakened abduction following a fall or minor trauma can occur. All right, so So that was rotator cuff impingement. Versus rotator cuff tear, this typically is due to an impingement of the supraspinatus tendon. And the rotator cuff tendinopathy or tendinitis can also be present with pain, but the weakness will not be present in tendinitis without a tear. So you need to have a tear to have weakness. If there's no weakness, then it's probably not going to be a tear. The rotator cuff tears usually occur after a fall on an outstretched arm in patients that are older than 40 years old. And the pain is going to be at the lateral shoulder. There's going to be limited painful active abduction and external rotation, and raising the arm above the shoulder is going to cause that pain. But weakness, there's going to be weakness, but the range of motion is going to be normal. On X-ray, it can also show calcific tendinitis, but that really has a low sensitivity. The MRI, that's going to be the most accurate. It's going to visualize soft tissue around the humeral head. And that's the way you can diagnose more accurately a rotator cuff tear. So the treatment for the tear is surgical. So an acute tear is going to be treated with surgery, and for the best results, you need to do the surgery within 6 weeks of the injury. All right, so that was rotator cuff tear. Next up, we have frozen shoulder syndrome or adhesive capsulitis. And here you have a markedly decreased range of motion in multiple planes. So the glenohumeral joint is going to lose its normal distensibility. That's due to chronic inflammation, fibrosis, and contracture of the joint capsule. And the causes would be idiopathic causes, we don't know, and secondary to underlying conditions like rotator cuff tendinopathy, which seems to be the most common. If you have a rotator cuff tendinopathy, that can lead to a frozen shoulder. Also subacromial bursitis, paralytic strokes, diabetes, or a humeral head fracture. Symptoms here would be gradual and an onset of shoulder stiffness with or without pain that limits the ability to flex and abduct or rotate the humerus. So when you're reaching overhead, there's going to be a limitation there with frozen shoulder. You really can't move, it's frozen. Diagnosis is confirmed on examination by more than 50% reduction in both passive and active ranges of motion. Next up, we have rupture of the tendon of the long head of the biceps. This is a funny one. It's a kind of, well, it's not really funny, but it's your Popeye sign. It's associated with overuse, especially in older patients. Popeye always seems a little older to me. And usually you hear a sudden onset of pain, or not here, there usually is a sudden onset of pain, and you hear an audible pop, and then you'll see a bulge, a visible bulge. It's kind of like it just retracted in there, and now you have this bulge. You didn't just become strong like Arnold Schwarzenegger or anything like that, or Popeye. It just looks like that because it popped. And you can report the patient can report weakness, but normal passive ranges of motion are going to be present. So again, normal range of motion. There can be weakness. It's just going to look funny with that visible bulge. They're going to tell you about an audible pop that occurred, and it's usually seen in older patients. That's rupture of long head of the biceps tendon. Okay, next up we have posterior shoulder dislocation versus anterior shoulder dislocation. Which one is the most common? And that's anterior. Anterior shoulder dislocation is going to be the most common form of shoulder dislocation. It's usually caused by a direct blow or from a fall on an outstretched arm. And the patient's going to hold their arm slightly abducted and externally rotated. So you kind of have to remember that. And it makes sense. They're holding their arm because it's dislocated, obviously, but it's abducted and externally rotated. Versus a posterior shoulder dislocation, this is much less common. It's caused by violent muscle contractions, and it's seen when there's a patient that has had a seizure or an electrocution injury, although posterior shoulder dislocation is the least of their problems if they've been electrocuted. And those are some of the violent causes of a posterior shoulder dislocation. So the presentation is that the shoulder is typically held oppositely of anterior shoulder dislocation. So in this case, in posterior shoulder dislocation, it's typically held in adduction and internal rotation, versus anterior shoulder dislocation is held in abduction and externally rotated. So adduction with internal rotation, that's seen in posterior shoulder dislocation. And there's also going to be a visible flattening of the anterior part of the shoulder. Obviously, it's going to be flat anteriorly because it all displaced posteriorly. And as well as prominence of the coracoid process. So that's going to show up a little bit more prominent, that coracoid process, because there's flat. Everything's anteriorly is flat. On radiographs, those can reveal an internal rotation of the humeral head with a circular appearance. So that's your light bulb sign. And the joint space is also going to be widened more than 6 millimeters. And that's also known as your rim sign. Or there can be two parallel cortical bones that form a line on the medial aspect of the humeral head, and that's called your trough line sign. Okay, a little bit more specific there. I doubt they're going to ask you that. The management is going to be managed by closed reduction in these cases. But it's pretty easily to identify. Flattened anterior shoulder after a violent muscle contraction like a seizure, an electrocution injury, you'll see posterior shoulder dislocation. And anterior, most common. All right, next up we have foot pain. The differential diagnosis of pain in the forefoot, or foot pain, this is going to be seen in arthritis, bursitis, also stress fractures, as well as a Morton's neuroma. Those are all foot pain causes. So some of the overview of running injuries of the foot and ankle. So they love to ask these questions. I guess a lot of test writers are runners, right? So, but no, it's because it's very common clinical presentation here. Runners can have various injuries on their foot. There's a stress fracture, plantar fasciitis can be one, Achilles tendinopathies, Morton's neuromas, like we mentioned, and tarsal tunnel syndrome. So for stress fractures, they're going to present as an insidious onset, focal pain in the navicular or the metatarsals, and risk factors would be an abrupt increase in intensity of the training, poor running mechanics, or a female with an eating disorder. What does that tell you? Is that somebody's doing something acutely different than what their body's normally used to. This is going to then put them at risk for fracturing themselves. They don't know how to run very properly, you can fracture yourself. And obviously a female with an eating disorder like bulimia, you can end up getting a stress fracture that way as well. So next up we have plantar fasciitis, and here we have pain on the plantar surface of the heel. And it's worse when they're initiating running or they take the first steps of the day. Whenever you kind of jump into things too quickly and start taking those first steps with a lot of pressure acutely on your foot, that can lead to a plantar fasciitis. And it's found at that plantar surface of the heel specifically. Now, Achilles tendinopathy is another one, and this is a burning pain or stiffness 2 to 6 centimeters above the posterior calcaneus. So think of a burning pain there, Achilles tendinopathy. A Morton's neuroma, this is going to be numbness or pain between the third and the fourth toes. Here, you have to remember it's a clicking sensation that you'll hear or feel when the space between the third and fourth toes are going to be squeezed together. And that's called a Mulder sign. That's for a Morton's neuroma, the third and the fourth toes, clicking sensation. And then finally, tarsal tunnel syndrome is going to be compression of the tibial nerve at the ankle. And because again, it's a nerve problem, they're gonna complain of burning sensations, numbness, and aching at the distal plantar surface of the foot and the toes. All right, moving on, we have arthritises, and that typically is in the metatarsal phalangeal joints. It's not really located to any single bony surface. It's just typically around the metatarsal phalangeal joints. There's also bursitis, which is caused by wearing poorly fitted shoes for a long time. This will end up causing inflammation between the metatarsal heads. So always change your sneakers or your footwear often. You don't want your feet to be always accustomed to one thing. That's a good tip. But anyway, they're just going to show on the vignette somebody who has either never changed their shoes, and the shoes have just slowly gotten worse and worse, not being able to properly support your feet, or they're poorly fitted, and this is going to cause imbalances there, causing inflammation between the metatarsal heads, causing an initial bursitis. All right, and then the Morton's neuroma, like we said earlier, this is pain between the third and the fourth toes on the plantar surface. You have your Mulder sign, that's clicking sensation and pain that occurs when you palpate and squeeze that metatarsal joint. And obviously it commonly occurs in runners. Maybe think of a runner named Morton. It's not a true neuroma, however, but a mechanically induced neuropathic degeneration of interdigital nerves. This will then cause numbness and pain and burning at the distal forefoot from the metatarsal head to the third and the fourth toes, which will then lead to worsening, which is worsened by walking on the hard surface, and wearing tight or high-heeled shoes can be one of them. The diagnosis is made clinically, and the treatment really is to give those metatarsal bones support, specifically with some kind of bar or a padded shoe insert, and this will then decrease the pressure on the metatarsal heads. And finally, surgery is usually only reserved for patients who have failed conservative management. So a Morton's neuroma, remember, pain between the third and the fourth toe, clicking sensation when they get squeezed together in a runner. All right. Plantar fasciitis, this is burning pain on the plantar surface of the foot that worsens with the first steps in the morning. Like we said earlier, it's a gradual improvement during the day, but then it gets worse by the end of the day due to that prolonged weight bearing. And it's common in runners because of that acute first initial impact that the runner does, and also because of the repeated micro trauma. Every time you hit the floor with your foot, you're causing a trauma, micro trauma, repeatedly over and over again, leading to a plantar fasciitis. And this can develop to local point tenderness on that plantar surface of the foot and the heel. On examination, there's point tenderness of the plantar surface of the heel. There you go. Okay, next we have tarsal tunnel syndrome. And in tarsal tunnel syndrome, this is compression of the tibial nerve when it passes through the ankle. And it's caused by a fracture of the ankle bones. So when the ankle bones get fractured, they displace, causing impingement of the tibial nerve, and that leading to tarsal tunnel syndrome. So because the nerve is involved, again, you have burning sensation, numbness, aching of the distal plantar foot, not the dorsal, just the distal plantar. And the surface of the foot, the toes, those sometimes can radiate to the calf. All right, but just think fracture of an ankle, and now you have a burning numbness sensation. That's possibly tarsal tunnel syndrome. Next up, you have tenosynovitis, and this is inflammation of the tendons and its tendon sheath, the synovial sheath, hence tenosynovitis, right? And it's usually seen in the hands and in the wrists, and it's due to an overuse injury following a bite or a puncture wound. So you get bit or you get punctured, and then that can cause inflammation in the tendon or the synovium there, tenosynovitis that way. And then that pain can be particularly seen during flexion or during extension. All right. So bursitis is next. The synovial sac. Remember, synovial sacs are going to alleviate the friction at the bony prominences and the ligamentous attachments. So that's what it does. It's like a little pillow or cushion. Pishin. Pishin is a word I just made up. Pillow and cushion. Pishin. Anyway, it's vulnerable to acute injury as well as infections and crystalline arthropathies and autoimmune disorders like rheumatoid arthritis. And the symptoms are pain and tenderness that can be exquisite, causing swelling and erythema at that site. On physical exam, they can have an active range of motion, or it can be painful, or passive range of motion that's normal, but mainly the active range of motion is decreased. The passive range of motion can be there, but either way, it's painful, and it can cause less pressure on the inflamed bursa. Next up, we have anserin bursitis, or pes anserin bursitis syndrome. They like to ask about this. Most patients don't have a true inflammation of the bursa, and the pain may be contributed by multiple regional structures. Remember, the pes anserinus, that's formed by a conjoined tendon. So you have the gracilis tendon, the sartorius tendon, and the semitendinosus, right? That's your pes anserinus. And the anserin bursa, that's going to be located anterior medially over the tibial plateau, just below that joint line of the knee and deep into the pes anserinus. The causes would be like an abnormal gait or trauma or overuse injury, and symptoms would be localized medial knee pain as well as focal tenderness over the anterior medial tibia just below that joint line. It's exacerbated by pressure from the opposite knee while lying on one side. So that opposite knee usually is the one that's on top, causing pressure on the bottom one. So the medial to medial, right? When you're lying on one side in bed or whatever, that's the way they're going to ask you is this person has pain on their medial aspect of the knee, and they sleep in that sideways like that on their side. There's going to be a valgus stress test done, but it doesn't exacerbate the pain. So that'll basically tell you that there's a normal medial collateral ligament. And the diagnosis is made clinical, although an x-ray can rule out any kind of concurrent osteoarthritis. And this doesn't cause any type of locking or joint fusion. All right, so that was pes anserinus syndrome, pes anserin bursitis, or pes anserinus pain syndrome, PAPS. Just remember, patients lying on his or her side, and it's in the medial aspect of the knee. All right, Baker cyst. So on a Baker cyst, this is due to excessive fluid production by inflamed synovium. It's usually seen in osteoarthritis, in rheumatoid arthritis, and in cartilage tears. This will lead to excessive fluid accumulation in that popliteal bursa, which is going to then expand and create a very tender mass in the popliteal fossa. Occasionally that mass will burst, and that releases all its contents dripping down into the calf due to gravity, right? And you'll get this pain in your calf. So because of that, guess what it resembles? A DVT. So a Baker cyst will resemble a DVT when it's ruptured. If it hasn't ruptured, it's just going to be a painful, tender mass in your popliteal fossa. Next up, we have prepatellar bursitis. This is your housemaid's knee. It's caused by, or like a nun, or I think they called it a nun's disease or something like that. Somebody who's been on their knees all day, a lot, and it's caused by chronic irritation of the anterior knee seen in occupations that require excessive kneeling. While other bursitis are usually non-infectious, an acute prepatellar bursitis is very commonly due to Staph aureus infection. And that's due from a penetrating trauma or repetitive friction or an extension from a local cellulitis as well. When you examine the patient, there's going to be pain with direct pressure and superficial cyst swelling over that patella with variable signs of inflammation. The diagnosis should be confirmed by an aspiration of bursal fluid for cell count and a gram stain. Now the treatment would be either positive gram stain or negative gram stain in culture. If it's negative gram stain, then you want to just actively do activity modification and give them NSAID. If it's a positive gram stain in culture, then you need to treat them with the proper antibiotics and obviously with drainage. You want to drain that area. Okay, so what are some of the differential diagnoses of anterior pain in a young patient? So young patients have three types of knee pain, right? You have your patellofemoral syndrome, you have your patellar tendonitis, and finally the Osgood-Schlatter disease. So a patellofemoral syndrome, think of a young female athlete that has subacute to chronic pain that increases when they're squatting or running, or if they have any type of prolonged sitting, or if they use the stairs. Gosh, that's like a combination of laziness and activeness. So it's an increase with squatting, running, prolonged sitting, or using the stairs. You get a positive patellofemoral compression test in a young female athlete. Think of patellofemoral syndrome. That's another thing. There's a lot of connections with the femoral bone and a female. And what's great about it is a female and femoral sound the same. They're almost spelled the same halfway through the word. So there you go. Next up, we have patellar tendonitis. And in patellar tendonitis, this typically presents in athletes as well, but it's specifically like a jumper, somebody who needs to be jumping, right? With episodic pain and tenderness at the inferior patella. So think of like a basketball player that's constantly jumping, track and field or whatever. And it's obviously I'm saying those two because it's in a young patient. So a patellar tendonitis is seen in a young athletic patient who jumps a lot versus a young female athlete that's either sitting or running up and down the stairs. That's patellofemoral syndrome. Patellar tendonitis is the jumper. And then Osgood-Schlatter disease is your pre-adolescent or adolescent athlete that has undergone a recent growth spurt. And here you have an increased pain with sports that's relieved by rest. And the clinical features also is going to be tenderness and swelling at the tibial tubercle. Okay, so for patellofemoral pain syndrome, like we said earlier, a little bit more in detail here. The risk factors here is an overuse injury. That's the most common because it could be because of sitting down too long. But the overuse injury is most commonly the problem. There's malalignment at the causing like angular deformities or not causing. If you have an angular deformity, that will lead to a malalignment problem that can lead to patellofemoral syndrome. Also weakness of the hip abductors and trauma. So it's a very common cause of chronic anterior knee pain in young athletic females. And this is going to be worsened by prolonged sitting as well. And that prolonged sitting is due to flexion, or it could be due to activity or climbing up and down the stairs. They can have crepitus and movement of the patella, with the movement of the patella, and it presents with a peripatellar pain. It's localized to the patella. So the diagnosis here is challenging. It's mainly based on the history and the physical exam. Patellofemoral compression tests can cause a pain elicited by extending the knee while compressing that patella into the trochlear groove and reproducing the pain with squatting or are highly suggestive. I mean, just explaining that is painful. Pressing that patella when you already have pain there. Ugh. But yeah, that's one of the ways to do it. There's no separation of tibial tuberosity seen on x-ray, and x-rays and MRIs are usually going to show, they usually don't show any type of abnormality, and it's only needed when the diagnosis is in doubt or the patient just doesn't improve as you would expect them to. So treatment is primarily mechanical treatment, so exercise to strengthen and stretch the thigh muscles, to strengthen the quadriceps and the knee extensors, as well as the hip abductors. And you want to avoid activities that aggravate the pain, that reduce intensity, like reduced intensity of exercise, especially running. So if you're running, it's like a no-no when you're trying to recuperate from patellofemoral syndrome. NSAIDs often prescribed, but these are not helpful because remember, this is more of a malalignment issue, something that's not very it's not an inflammation per se, it's more of like the area around the knee is weak. And you have persistence in persistence is often required on part of the patient, so improvement could take weeks to months. So it depends mainly on whether the patient's actually going to put in the time and the effort to work out and improve that that area. Next up, we have patellar tendonitis, and this is an overuse syndrome with repetitive jumping and kicking, like we said, in occupations that have repetitive forceful knee extensions. The presentation is an episodic anterior knee pain after exercise, but unlike Osgood-Schlatter disease, the patient has point tenderness over the inferior pole of the patella and the patellar tendon. So that's patellar tendonitis. Now, Osgood-Schlatter disease, here, this is seen in early adolescence, so around 13 to 14 year olds, specifically. If they're boys, they're going to be 13 to 14 year olds. But if they're girls, it's going to be obviously younger because girls mature earlier. That's 10 to 11 years of age in a girl, 13 to 14 year olds in a boy. The point is that it's happening in periods of rapid growth, right? So the quadriceps is going to put traction on the apophysis of the tibial tubercle, where the patellar tendon inserts. So sports like excessive running and jumping and kneeling can lead to a traction apophysitis, where it just traction, meaning it pulled too much. And that's your Osgood-Schlatter disease, worsened by activity and relieved by rest. And it's also seen bilaterally in only 1 out of 4 1/4 of the cases. So it's most commonly unilateral. On physical exam, there's also going to be edema and tenderness over that tibial tubercle. There's also going to be a firm mass that can sometimes be felt due to the heterotropic bone formation. And pain is going to be reproducible by extending the knee against resistance. Again, there's really no radiographic findings other than soft tissue swelling, lifting of the tubercle from the shaft, and or irregularities or fragmentation of the tubercle. That's what you'd see on radiograph. So it's kind of like a little flap that's coming up. It's because of the traction that the patella is happening on the tibial tubercle. And treatment would be activity restriction as well as stretching exercises and NSAID uses. Next up, we have tibial osteomyelitis, and this is usually usually bacterial osteomyelitis. On physical exam, there's going to be pain and swelling and tenderness, as well as erythema because it's an infection, and it's also an inflammation. There's also going to be refusal to bear weight on that affected extremity, and the signs and symptoms systemic symptoms can also be present. The pain does not remit with rest with tibial osteomyelitis. When you have patellar fractures, Patellar fractures obviously are caused by a direct blow to the knee or a sudden forceful load, like if you're falling from a really tall second floor or first, something like that. There's acute swelling occurs, tenderness, and the inability to extend the knee. It's fractured, the patellar fracture. Next up, we have patellar dislocation, and this occurs after quick lateral movements around a flexed knee. So on physical exam, you'll see a flexed knee with a patella that's displaced laterally. That's kind of weird looking. The patella is just like shifted to the left, to the right. Well, laterally. And versus Osgood Schlatter, which is the patella is moved upwards because of the traction apophysitis that happened on the tibial tubercle. Okay, so patellar dislocation, patella moves displaced laterally, patellar fracture, patella got hit by a crowbar or whatever and got fractured, or fell from a great height, got fractured. Next up is septic arthritis. This is a little bit more in depth, obviously. This involves a joint space that's proper, the joint space proper, not the joint space that's proper, because it didn't go to school, right? The joint space. Well, I'm really doing the bad jokes today. Anyway, and septic arthritis, it involves a joint space, the joint space proper, and not an anterior tissue. This can cause an acute pain, joint effusion, and it can also have with or without fever. Sometimes in my notes I put positive or negative, but it's with or without. All right, anyway, with or without fever, with or without chills, and leukocytosis. And the pain is seen on active and passive ranges of motion. And the onset usually occurs over days and not hours like in gout. It's most commonly due to a gram-positive infection rather than gram-negatives and anaerobes, so think of gram-positives in this case. Fungal arthritis is usually due to a candida species, uncommon in non-immunocompromised patients, less acute and dramatic, and it usually precedes by a recent invasive candida infection. Yeah, that's just a general rule of thumb. Fungal infections are usually not seen in somebody who's more or less healthy. It's only seen it's more commonly seen in immunocompromised patients. All right, so septic arthritis, the risk factors are an abnormal joint caused by either osteoarthritis, rheumatoid arthritis. There can also be a prosthetic joint involved or gout. And other risk factors are patients older than 80. Also diabetes, if they have any kind of IV drug abuse or alcoholism, and an intra-articular glucocorticoid injection can also be a cause of a septic arthritis. So some of the clinical features of septic arthritis would be an acute monoarthritis. So it's a hot, swollen joint that has decreased range of motion, fever, obviously, and elevated ESR, as well as CRP, C-reactive protein, or peptide. The diagnosis is made with a blood culture. Blood cultures are going to be positive in about 50% of the cases. So those should be drawn before you do the antibiotics, so you know what exactly what antibiotics to give. And the synovial fluid analysis is going to show, obviously, leukocytosis, so more than 50,000. You should do a gram stain of that and culture. And the initial treatment is going to be if it's gram positive, you want to give them vancomycin. And by the way, septic arthritis patients, they don't go home. They obviously they stay in the hospital. Okay. So gram positive cockeye, give them vancomycin. If it's gram negative rod, then you can give them a third generation cephalosporin. But if on microscopy it comes back negative and you have no idea, treat them with both, vancomycin with a third generation cephalosporin, especially if they're immunocompromised. You want to just cover for both little buggers there. So the prompt therapy with IV antibiotics and adequate joint drainage is done to finally prevent any kind of further joint destruction, right? So you kind of need to tap it, drain it, analyze it, culture it, then properly treat it as soon as possible. All right, next up we have iliotibial band syndrome. And this is an overuse injury with poorly localized pain at the lateral knee. Tenderness is going to be seen over the lateral femoral condyle during flexion and extension, and it doesn't cause a locking and joint infusion. So that was iliotibial band syndrome, an overuse injury. All right, it's seen in the lateral knee. Okay, next up we're going to be talking about special tests for knee examinations. All right, so what are some of these special tests? Well, we have the MCL or LCL injury. We have an ACL injury. There's also PCL and the meniscal tear. So all these are going to be tests for each of those ligament tears. So for instance, let's start off with the MCL, the medial collateral ligament, or the lateral collateral ligament injury. So it's for the valgus stress test. You want to place one hand above the knee and along the lateral thigh, and then you place the other hand along the medial leg, and you apply outward pressure along that calf. And if there's any kind of laxity, that's going to indicate an MCL injury. Versus the varus stress test, this is for the LCL injury, lateral collateral ligament. This is you place one hand above the knee along the medial thigh, and you place the other hand on the lateral leg, and then you apply inward pressure along the calf, and that lateral laxity is your lateral collateral ligament injury. For the anterior cruciate ligament, that one's the easiest one. That's your drawer sign. You have the patient lie supine with the knee flexed at around 90 degrees, and you want to grip the proximal tibia with both hands and pull anteriorly. That's your drawer test, like if you're opening up a drawer. Then you have the Latchman's test, and that's when you place the knee at 30 degrees flexion. You want to stabilize the distal femur with one hand and pull on the proximal tibia anteriorly with the other hand. A significant anterior displacement of the tibia with either one of those tests, with either the Latchman or the anterior drawer test, is going to indicate an anterior collateral ligament injury. Next up, we have the PCL injury, and this would be a posterior drawer test, and the knee here again is flexed at 90 degrees, and you want to stabilize the foot, and you want to grasp that tibia with both hands and push posteriorly. And then if you have displacement, that indicates a PCL injury. It's kind of the opposite of the ACL. And there's also the posterior sag test, where you place the patient supine with the legs flexed at around 45 degrees, and the knees are flexed to about 90 degrees, and the feet lie flat on the table. A PCL injury causes the affected tibia to sag backwards relative to the femur. So that's the posterior cruciate ligament. And finally, you have a couple of tests for the meniscal tears, and these are the Thessali test, the Apley test, not to be confused with the Apley maneuver or the Epley maneuver. That's for the ear. This is the Apley test, and then you have your McMurray test. So the Thessali test, this is the patient stands on one leg with the knee flexed 20 degrees, and there's pain or locking with internal or external knee rotation. That suggests a meniscal tear. Hint on the words locking, pain or locking. Then you have the Apley test, which is the patient's prone and the knees flexed to 90 degrees. You want to stabilize the patient's thigh with the examiner's knee or hand. You want to press the patient's heel directly towards the floor while internally and externally rotating the foot. Focal pain is seen with compression, and if that's so, that indicates a meniscal tear. And then finally, you have your McMurray test, which is a passive knee flexion or extension while placing the examiner's thumb or index finger on the medial and lateral joint lines. If you hear a clicking with passive movements or a medial to lateral rotation, that suggests a meniscal tear. All right, so going a little bit more in detail with MCL injuries, these are caused by blows to the lateral knee or forceful leg abduction and twisting or pivoting injuries. So you're going to see these a lot in athletes, specifically football or contact sports. A positive medial knee tenderness and ecchymosis is seen, and an absent catching during extension or rotation. Acute effusion or hemarthrosis is usually absent unless the ACL is also damaged. So there's not going to really be hemarthrosis here. MRI is going to be most sensitive test, but it's the MRI is reserved for a patient who is being considered for surgery. So the treatment, mostly it's not very operative. You just do the RICE treatment, rest, ice, compression, and elevation. And analgesics are given with progressive return to activity as tolerated. So that was an MCL injury. Next we have anterior cruciate ligament injury. So how does this happen is rapid deceleration from a direct change or a pivoting on the lower extremity of the foot that's planted. Okay, so it's kind of the same. It's a twisting or pivoting injury with the anterior cruciate ligament as well as the MCL ligament. However, the symptoms here are a rapid onset and may be severe. It could be a popping sensation at the time of the injury. They like to ask that too, with significant swelling or effusion and hemarthrosis. So here you'll have the hemarthrosis versus MCL probably won't by itself. And the ACL injury is also going to have a joint instability as well. On exam, there's going to be an anterior laxity of the tibia that's relative to the femur. So you get that positive anterior drawer test or the Latchman test like we just said. And the diagnosis is done with an MRI. Treatment, again, would be the RICE treatment, rest, ice, compression, and elevation. And then with or without surgery. So surgery isn't really 100% needed in some cases. Then you have meniscal tears, and the etiology here is that it's seen in younger patients and in older patients. But in younger patients, it's due to rotational forces on the foot that's planted on the ground. Versus in older patients, it's going to be because of degeneration of the meniscus, of that cartilage. So the symptoms here, again, you can have a popping sensation with meniscal tears. There can be catching or locking and a reduced range of motion. And the symptoms are going to be slow onset joint effusions. On examination, they're going to have joint line tenderness. There's going to be pain or catching in the provocative test. So when you do the test like the Thackeray and the McMurray, there's going to be catching. And when it catches, that produces pain. So that's your locking kind of catching symptom. The diagnosis is done with an MRI or with an arthroscopy, but MRI is a little bit better initially, obviously. And then management is mild. If there's mild symptoms in older patients, you want to do the rest. And you can also give NSAIDs as well as activity modifications. But if the symptoms persist, meaning that they last more than like 3 to 4 weeks, then you can go on and manage them with surgery. A medial meniscus tear is going to be more common than lateral tears, so that's something to keep in mind. If you're stuck in between both, I would say medial because it's more common. There's reduced extension sensitivity or sensation. Reduced extension, reduced sensation, or instability of the knee effusion, as the meniscus is not directly perfused. So the effusion is not going to be apparent here until several hours with a medial meniscus tear. And on x-ray, older patients with tears are going to be due to degeneration. Like we said, that's also signs of osteoarthritis. But a normal x-ray in a young patient, it can be seen with a traumatic tear. So that's something to keep in mind, that the x-ray could be normal in a young patient going to look normal. And the diagnosis is going to be confirmed by visualizing it either with an MRI that's better than an arthroscopy. Then, so hip pain. Let's talk about hip pain. So for hip pain, there's a superior gluteal nerve, and that's going to innervate the gluteus medius and the gluteus minimus, right? The superior gluteus nerve. Weakness can be due to a neuromuscular disease or impingement or trauma of that nerve, as well as inflammatory myopathies, and something called a positive Trendelenburg sign or a Trendelenburg gait. That's for hip pain. Okay, so now we're going to start talking about avascular necrosis here. So since we're on the topic of pain here, so in avascular necrosis, this can happen because of several etiologies. You have steroid uses. Remember, steroids affect on osteocytes, causing trabecular thinning. The steroids can actually thin out the trabecular network and cause collapse over months to years, as well as abnormal lipid levels that can lead to microembolizations, and that can lead to an osteonecrosis, all due to steroid use. That's something to keep in mind. Also, alcohol abuse, systemic lupus erythematosus, so lupus. Antiphospholipid syndrome can cause avascular necrosis. Hemoglobinopathies such as sickle cell disease, infections like osteomyelitis or HIV, renal transplants, and decompression sickness can lead to avascular necrosis. So how do they manifest? With groin pain on weight bearing. Pain can be on hip abduction and internal rotation. There's going to be progressive hip or thigh pain, right? The pain is worse after the activity, but rest and night pain often are going to present in advanced diseases, not in acute diseases. So if it's at night or at rest, it's already being progressive, obviously. And then along with joint instability and a decreased range of motion with avascular necrosis. There's not going to be any erythema or swelling or point tenderness because it's already necrosed at this point. Laboratory findings is going to be a normal white blood cell count as well as normal erythrocyte sedimentation rates and CRPs. And on radiological imaging, there's going to be that crescent sign seen in advanced stages. Otherwise, you'll have normal physical findings on x-rays initially. And the MRI is going to be the most sensitive. Remember, MRIs visualize the boundaries between normal and ischemic bone, as well as the zones of hypervascularity. Avascular necrosis, that's caused by an occlusion of the end arteries, so microocclusions, that supply the femoral head. Abnormal endothelial functionings or an increase in intraosseous pressure can then lead to necrosis and then collapse of that periarticular bone and cartilage. The femoral head is going to be supplied by two main sources. There's going to be ascending arteries and the foveal artery that lie within the ligamentous teres, right? The foveal artery is in patients in early life, but then they become obliterated later in life. Children are less prone to avascular necrosis because of that artery as compared to adults, because there's more vascular irrigation there due to that extra artery when you're a child. And sickle cell disease obviously leads to an occlusion of the microcirculation in bone by the sickled blood cells and increases intraosseous pressure due to bone marrow hyperplasia. That leads to an osteonecrosis. Lateral femoral cutaneous nerve at the waist, and that's going to cause a burning pain and paresthesia at the lateral thigh. And the symptoms are unaffected with motion, so they're just going to have that pain on their lateral thigh due to a compression of the lateral femoral cutaneous nerve. And that's called neuralgia paresthetica. All right, next up we're going to be talking about back pain. So this is going to be an algorithm on the evolution of back pain. So let's say you have acute low back pain. So at this point, you got to find out, do they have cord compression signs and symptoms, like saddle anesthesia, for instance? Do they have any kind of red flags or sciatica symptoms, like weight loss or whatever? And or do they don't have any red flags, sciatica or cord compression? So it's just acute low back pain. So let's say they don't have any type of red flag symptoms, they don't have sciatica or cord compression, but they do have acute low back pain, then the therapy is going to be conservative. So it's going to be around 4 to 6 weeks of conservative therapy. If they get better, they get better. If they don't, then you're going to require x-rays of the back as well as an ESR. And if that's normal, then again, conservative therapy and close follow-up. However, if the x-rays do come back abnormal, then you got to progress and do an MRI. From an x-ray, you got to do the MRI, and again, if there's improvement, you go on to doing conservative therapy and close follow-up. Now, let's say they just had cord compression signs and symptoms, like cauda equina symptom and sample anesthesia. You go straight into doing an MRI. And if they have red flag symptoms or sciatica, here you want to actually do x-rays of the back as well as an ESR. And if that comes back abnormal, MRI. So the only times you do x-ray is when you have red flag symptoms, sciatica, you go and do the x-ray of the back. Or if you had no red flags or sciatica or cord compression, but conservative therapy failed, you do an x-ray. And if any of those times the x-ray comes back abnormal or the erythrocyte sedimentation rate comes back abnormal, you want to then do an MRI. So what are some of the red flags? Like we said, weight loss would be one of them, obviously. Age is greater than 50, pain at night, constitutional symptoms, which is like weight loss, history of malignancy, trauma, IV drug use, and infectious risks, like somebody who has who is immunocompromised, or more than 1 month without any kind of improvement. Those are all red flags. So conservative therapy, when we say conservative therapy, is done with NSAIDs. It's better than giving them acetaminophen in patients with no red flags. It's mostly lower back pain and musculoskeletal origin, but the red flags are going to suggest something a little bit more systemic, right? There could be a herniated disc or some kind of bony abnormality. This can lead to, like, let's say a lytic lesion or a compression fracture that can be present. And then you do the MRI to look for disc disease or any kind of spinal infection, as well as cancers. And common cancers that metastasize to the spine or to the bone are going to be breast cancer, lung, prostate cancer, multiple myeloma, melanoma, renal cancers, and thyroid cancers. All those can metastasize to the bone. So what are some of the causes of low back pain? So you have musculoskeletal causes, inflammatory causes, malignancies, and infections. So under musculoskeletal, it's going to depend on what's the condition. So if it's like a mechanical condition, let's say like a muscle strain, a spasm, or a degenerative arthritis, those are like the most common, then the clinical clues here are going to have a normal neurological examination, meaning muscle strains pain can also radiate to the butt and the posterior thigh, but the pain below the knee is characteristic of a herniated disc. So if if they have pain in the back as well as pain below the knee, think of a herniated disc at that point. For other musculoskeletal conditions causing low back pain would be a herniation of the nucleus pulposus or disc disease. That's a radiculopathy. That's usually between L4 to L5. They like to ask that, as well as positive straight leg tests. And that's a radiation that happens below the knee. Cross the straight leg test is also specific. That's the straight leg test. And a positive possible neurological defects can be because of a herniated nucleus pulposus or disc disease. Another musculoskeletal condition could be like spinal stenosis. And here the clinical clues would be like pseudoclaudication, that they get better with the spine flexion, worse with extension or older age. And then compression fracture, this is seen in older age if there's any kind of trauma or fall, and it's more common in women. And those are all musculoskeletal causes of low back pain. You have compression fracture, spinal stenosis, herniated discs, and muscle strain, spasms, and degenerative arthritis. Now, inflammatory causes of low back pain, here we have your ankylosing spondylitis, reactive arthritis, psoriatic arthritis, as well as inflammatory bowel disease. And the clinical clues here would be that they get better with activity or exercise, but they don't get better with rest. It's a gradual type of onset, and the HLE-B27 is going to be present. For malignancy causing low back pain, obviously that would be metastasis, would be cancer to the bone. And so clinical clues obviously are a history of previous malignancy, somebody that was older than 50 years of age, the pain is worse at night, not relieved by rest. They have unintentional weight loss, Cauda-Equina syndrome. They can also have weakness, urine retention, urinary incontinence, as well as saddle anesthesia. Those are all clues for malignancy. And then finally, infectious causes that cause back pain would be like osteomyelitis, discitis, and abscesses. And here the clues are going to be a recent kind of infection, any type of IV drug abuse, diabetes, fever with exquisitely point tenderness. And that generally occurs in patients that recently had overlying soft tissue infections or a bacteremia. And remember that on labs, that C-reactive peptide and the ESR are going to be elevated. So how would you manage low back pain? This is usually managed in 3 different categories: if it's acute, if it's chronic, or through secondary prevention. So if it's acute pain, you want to maintain moderate activity. You want to give them NSAIDs or acetaminophen. You also want to consider if they can benefit from muscle relaxants, as well as spinal manipulation, and a brief course of opioids. Acute means that it's, remember, less than 4 weeks, and most patients will have a resolution without any type of additional treatment with acute back pain. Chronic back pain obviously is more than 4 weeks, usually more than even 12 weeks. And here is an intermittent use of NSAIDs or acetaminophen. Exercise therapy is how you can manage them as well. And you want to consider TCAs or duloxetine with chronic back pain. And then secondary prevention, obviously you want to prevent having back pain by exercising, as well as education about good back health. Next up, we have cervical spondylotic myelopathy. They like to ask this one a lot. It's a degenerative change in the cervical spine seen in older patients, and then it can cause weakness and paresthesias, as well as loss of motor controls. The neck and upper extremity symptoms are usually going to be present, and patients will usually show signs of bilateral upper motor neuron weakness, like hyperreflexia and upgoing plantars. And they'll also have bilateral sensory deficits, and on MRI, that's going to be used for the diagnosis. For cervical spondylosis, that's our next one, this affects about 10% of people older than 50 years old, and they have a history of chronic neck pain. Well, that's typical history of chronic neck pain. And they're going to have limited neck rotation as well as lateral bending. And that's due to osteoarthritis, and secondly, it could be due to a muscle spasm. A sensory deficit due to osteophyte-induced radiculopathy and isolated sensory abnormalities are associated with a good prognosis. And typical radiological findings with cervical spondylosis is going to be a bone spur and sclerotic facet joints. They love to ask about the bone spurs. Osteoarthritic changes are very common in asymptomatic patients older than 50 years old. And other findings can be like narrowing of the discs and narrowing of the spaces, as well as hypertrophic vertebral bodies. All right, next up, we're going to be talking about vertebral osteomyelitis. So here, the risk factors are going to be your IV drug abusers. They love to use those as your primary risk factors for osteomyelitis. there's a high index of suspicion with them. There's a history of distant site infections. It could be sickle cell anemia and immunosuppressed patients as well. But IV drug users are going to be the #1 cause for vertebral osteomyelitis. The spine is going to be the frequent site of the infection, and the organisms most commonly it's due to Staph aureus, but it's also can be caused by a gram-negative organism. The symptoms are going to be back pain that's not relieved by rest, and the fever is going to be inconsistent. So they could have a fever, they may not have fever, or the fever comes and goes. On physical exam, they can have tenderness to very gentle percussion over the involved spinous process. And that's going to be the most important clue, that they do have tenderness when you palpate, very gentle palpation. And on labs, the leukocytosis is going to be inconsistent. Platelets are usually going to be increased because they're a marker of inflammatory stress responses, as well as an increase in ESR, and that's going to be even greater than 100. And an MRI, that's going to be done as the most sensitive diagnostic test. So they do like to ask, what is the most sensitive test for vertebral osteomyelitis? Something like that. They're not going to be that straightforward, but it's going to be an MRI. And the treatment would be long-term IV antibiotics with or without surgery. All right, next up we have lumbosacral strain. Sorry. It's the most common cause of back pain, and there's a lifetime risk of about 80%. The signs and symptoms are going to be acute onset of back pain after a physical exertion. There's no types of radiation, no neurological deficits involved, and on physical exam there could be local tenderness and contraction of the paraspinal muscles. On neurological examination, that's going to be normal, and then the straight leg raise test is also going to be normal. So how do you treat these patients? It's with NSAIDs and early mobilization. So the main thing here is to prevent, right? So proper patient education is important. The education should emphasize on the importance of strengthening and supporting those muscles, including the abdominal muscles, by exercising regularly and choosing appropriate sleeping postures. Like, you want to avoid sleeping on your stomach, in other words, and learning proper techniques for bending and lifting the objects. Exercises with repetitive twisting and bending should be avoided in lumbosacral strains, and it's important to bend at the knee, not at the waist. I think we all know that, but it's just important to always emphasize on that. While lifting an object, a person should always bend the knees and keep your back straight, and that technique is really useful in preventing strains and back injuries. Warm-up exercises should be done before any kind of sporting activities to prevent any kind of lumbosacral strain. All right, so that's going to be the most common cause of back pain. So next one, we have lumbar disc herniation, and this is an acute back pain with or without radiation to the unilateral lower legs, and it's usually causing like a sciatica. They're going to be able to recall the inciting event, and it's aggravated by either activity or lumbar flexion, and it gets better with rest, right? The spine is not tender to palpation, so that's a good one. When they're going to say in the vignette, they palpate the back and there's no pain there. And the treatment is mostly spontaneous resolution of symptoms. Initially, the management is going to be focused on acute relief of the symptoms. You can do NSAID drugs or acetaminophen, which are preferred as first-line drugs. You can also use short-term opiates and muscle relaxants. Those can be considered in patients that have persistent pain, but that's associated with significant sedation, so it's kind of like not first line. First line is always NSAIDs. Also, activity modification is often advisable, but the patient should be encouraged to maintain a moderate physical activity. Okay, so that was lumbar disc herniation. Remember, no pain when palpation. Lumbar spinal stenosis, now this is narrowing of the spinal canal with compression of one or more spinal nerve roots. It's not a spinal nerve compression in itself. It's more of the compression of the spinal nerve root. And this is due to narrowing of the intraspinal canal, which is your central canal, the lateral recess or the neural foramen, and it's primarily seen in degenerative arthritises with osteophyte formations affecting the facet joints. And this is going to be your spondyloses, right? And other factors here would be hypertrophy of the ligamentum flavium and bulging of the intravertebral discs. So when that happens, you can also have degenerative disc disease as well as spondylolithasis, and that is displacement of one of the vertebral bodies relative to the other vertebral body. And it's mostly seen in patients that are older than 60 years of age with lumbar spinal stenosis. Here, the most important one to figure out, to point out in a vignette is that the signs and symptoms are posture dependent, right? So there's back pain that radiates to the buttocks and to the thigh. There's extension of the lumbar spine, like the patient is going to be standing and walking upright, further narrowing the spinal canal and worsening symptoms, and it's relieved by flexing the lumbar region. So like they get better when they're walking uphill or they're leaning over on a cane. That's another reason why a lot of patients in this age bracket prefer bike riding as a form of exercise because they're bent forward, right? So because they're bent forward, they have less strain on their back. An onset of the pain with walking is referred to as neurogenic claudication, as it can be resembling a vascular claudication, which is like pain with walking relieved by rest. Also, neurogenic claudication is relieved by walking and leaning forward. And when they get better when leaning forward, that's your shopping cart sign. And then exercise with the spine flex, like cycling, like we said earlier, it does not initiate the symptoms. So they're not going to say that it's worse with cycling. They might even say that they have this pain, but when they cycle, it doesn't hurt. So, and that's your shopping cart sign. It could be associated with numbness and paresthesias, and the image modality of choice here would be your MRI. That's confirmed with an MRI. The treatment is mostly going to be conservative, and physical therapy and exercise can require surgical intervention. All right, so it's mainly physical therapy, exercise, and some of them can even go on to require surgical intervention. Okay, next up we have neurogenic versus vascular claudication, and here we're going to describe the symptoms, what you see on examination, and how you diagnose each one. So with neurogenic claudication, remember this is a posture-dependent pain. This is also known as pseudoclaudication, neurogenic claudication. It's the lumbar extension worsens the pain, so like walking downhill. A lumbar flexion is going to relieve the pain, which is walking while bent forward. So it's kind of similar to spinal stenosis, right? There's a lower extremity numbness and tingling, however, with lower extremity weakness and low back pain. On examination, patients with neurogenic claudication have normal pulses. They frequently have normal examination findings, and the diagnostic choice is an MRI of the spine. So it really looks like a spinal stenosis, except you're going to get some neurogenic problems here. So which is also seen in spinal stenosis. So it might be a kind of difficult to differentiate. Next up is vascular claudication. So neurogenic claudication is what we just spoke about. Vascular claudication is an externally dependent pain. The pain is relieved with rest, but not with bending forward or while walking. There's lower extremity cramping and tightness, and there's no significant lower extremity weakness. Possible butt pain and thigh pain to the calf, or foot pain as well. On examination, they can have decreased pulses, cool extremities, decreased in hair growth, pallor and leg elevation. So as you raise the leg up, it'll get pale. And the diagnosis here is going to be an ankle brachial index, because here we're the cause of the claudication is vascular. So Here we have a vascular problem causing it, versus neurogenic claudication is a neurological problem. That's why MRI is better for neurogenic, and ankle brachial index is for vascular claudication. Now, next up we have impingement of the lumbar nerve roots. And impingement can cause significant pain in the posterior hip, in the thigh, or in the lower leg. The hip mobility can be normal, but it may have exacerbation of pain on hip flexion as well as knee extension. So a straight leg raise is going to be initiating pain. We're going to be talking about vertebral compression fractures, its etiologies, clinically how they present with their complications. So for vertebral compression fractures, obviously trauma is going to be number one, but there's also osteoporosis can be a cause of it, as well as osteomalacia, infections such as osteomyelitis, any type of bone metastasis or metabolic issues like hyperparathyroidism specifically, and then Paget's disease. These are all etiologies that can lead to a vertebral compression fracture. Clinically, they're going to present either chronologically or acutely. So how are we going to distinguish them? Acutely, obviously, they're going to have low back pain acutely with decreased spinal mobility. The pain is going to increase with standing, walking, or lying on the back, and there's going to be tenderness at the affected level. So here, remember, vertebral compression fracture is going to be tenderness at the level, but lumbosacral strain, that one, or lumbar herniation did not. All right. Now, chronic causes they'll present without any pain. They'll have progressive kyphosis and a loss of stature, right? So every year it's going to lead to about a 1 centimeter decrease in height with a vertebral compression fracture if it's chronic. And since they don't have any pain, they're not really going to complain about anything other than they're just having progressive kyphosis, right? They're bending forward. Complications would be an increased risk of future fractures, because if it's fracturing there, it can spread and fracture anywhere else or fracture in the same place. Also, hyperkyphosis can be a complication, possibly leading to a protuberant abdomen, early satiety, weight loss, and decrease in respiratory capacities. Now, neurological examination is typically going to be normal. They're going to have loss of deep tendon reflexes. That's the most common in the elderly, especially in elderly patients above 70 years old. And it's not related to a vertebral compression fracture. Okay. The following is going to be ankylosing spondylitis. So now we're going to be talking about seronegative spondyloarthropathy. So the first one would be ankylosing spondylitis. Now, this is an inflammatory back pain, and it's seen relatively young age, insidious onset at ages less than 40 years old. Symptoms could be more than 3 months, and it's relieved when they're exercising, but it doesn't get better with rest, only with exercise. And the pain, there can be nocturnal pain associated with ankylosing spondylitis. On exam, they're also going to have some type of arthritis, like a sacroiliitis, and there's going to be reduced chest expansion as well as spinal mobility. Remember, the spinal rigidity increases the risk of vertebral fractures with minimal trauma, so these patients can be at risk of vertebral fractures as well. And additional findings, they can have thoracic wedging and hyperkyphosis as well. And because it hurts their back whenever they're moving, so if they're taking deep breaths in, that deep breath, when the chest expands, it could compress into the spine and cause pain. So their chest expansions are going to be reduced. Also, enthesitis, right? And that's tenderness at the tendon insertion sites. Also, dactylitis, which is swelling of the fingers and the toes, and uveitis. So they like to ask the uveitis part, specifically anterior uveitis or iritis. That's the most common extra-articular manifestation with ankylosing spondylitis. The inflammation of the uvea tract, so the iris, the ciliary body, and the choroid around the eye, they're going to be intense pain as well as photophobia in one eye. Now, complications is osteoporosis, vertebral fractures. There can be aortic regurgitation, as well as cauda equina syndrome. So in osteoporosis, remember, osteopenia and osteoporosis, that's going to increase osteoclastic activity in the setting of chronic inflammation, and it's mediated by inflammatory responses with TNF alpha, like we know, and IL-6. Aortic regurgitation, that's going to be due to scarring of the valve cups. So those are complications of ankylosing spondylitis. On labs, obviously you have your HLA-B27 association, and whenever there's an inflammation, you're going to have increase in ESR and CRP. So that's not going to tell you much, but the HLA-B27, we know that that's going to be increased. On imaging, you'll see on X-ray sacroiliac joints going to be affected. And also an MRI of the sacroiliac joints can be good, but the X-ray of the sacroiliac joints are going to be the most important initial one. Okay, so when you have sacroiliitis, the X-ray is going to be the best way to confirm the diagnosis, right? So it may be really early on. You can do an X-ray. An MRI can then confirm cases where the fusion of vertebral bodies with ossification and of the intervertebral discs, and that's your bamboo sign. So they love to ask the bamboo sign, but they're never going to say bamboo sign on the vignette. They're going to describe what a bamboo sign is, and that's fusion of the vertebral bodies with ossification of intravertebral discs. Apparently, it's just a lot more fun for them to explain what bamboo spine is instead of saying bamboo spine. But anyway, ossification of intervertebral discs with vertebral body fusion. All right. Then you have enthesitis, and this is inflammation and pain at the site where the tendons and ligaments attach to the bone. It's commonly due to a tendon or ligament stress, and this manifests as an acute swelling and pain. On physical exam, there could be tenderness at the site of tendon insertions, because remember, this is where enthesitis is where you have pain at tendon insertion points, like we said earlier. There's an insertion of the Achilles tendon at the heel. That's the most common site of presentation, and that worsens with activity. So there can be lower back pain that improves with activity, and that can resolve or can involve costosternal junction, the shoulders, the elbows, the hips, as well as the iliac crest, and the tibial tuberosity and other sites as well. So chronically, it can lead to fibrosis and calcification, and it can also be associated, it can be isolated to a specific point, like in plantar fasciitis, it's isolated, but characteristic findings in spondyloarthropathies, such as ankylosing spondylitis, is more common. Psoriatic arthritis, as well as reactive arthritis, can be present in multiple sites. It's really important that you check out some of the images here for like uveitis and iritis, because they love to put images, and these images can throw you off if you've never seen them before. All right, next up we have psoriatic arthritis, and clinically the features of psoriatic arthritis are going to be distal interphalangeal joint involvement. There can be asymmetric oligoarthritis, symmetric polyarthritis, similar to rheumatoid arthritis. Also arthritis mutilans, which is a deforming kind of arthritis or destructive arthritis. And then you have your spondyloarthritides like sacroiliitis and spondylitis. Soft tissue and nail involvement for psoriatic arthritis. Here you have your enthesitis or inflammation of the tendon insertion site to the bone. Your sausage digits of dactylitis of the toes of the fingers. Also nail pitting and onycholysis, which is separation of the nail bed. And swelling of the hands and the feet with pitting edema. All right, and then skin lesions, arthritis these precede skin diseases in 15% of patients. Remember the white plaques with the silvery scales? So those skin lesions are present, but they're not yet diagnostic in about 15% of patients. So the skin lesions aren't something to be particularly helpful in diagnosing a psoriatic arthritis. You kind of need other involvements. So morning stiffness is one presentation, and that's present in most inflammatory arthritis. Sausage digits, that's the big one, with diffusely swollen fingers. And treatment options, obviously NSAIDs, also methotrexate and anti-TNF agents can work for psoriatic arthritis. Now, reactive arthritis, this is a type of seronegative spondyloarthropathy, and it's usually resulting from an enteric or a GU infection by either Shigella, Salmonella, Yersinia, Campylobacter, or C. diff, right? There's a triad of non-gonococcal urethritis, asymmetrical oligoarthritis, and conjunctivitis. So it's the well-known can't see, can't pee, can't climb a tree, right? And that often involves the knee and the sacroiliac spine. In addition to the classic triad, you have mucocutaneous lesions, and they can also get enthesitis, specifically Achilles tendonitis or Achilles tendon pain, are more common findings. There also can be malaise and characteristic cutaneous findings like keratoderma, blenorrhagica, and ballantitis circinata? I don't know. Ballantitis. Those are also present. But can't see, can't pee, can't climb a tree. Just remember those three. It's never let me down in any question, even when they're trying to be sneaky about it. There's only a couple of ways you can go around describing each one of those. I can't see, can't pee, or climb a tree. So not all those symptoms are present, however. So if there's high suspicion for reactive arthritis, in cases of any kind of asymmetrical oligoarthritis associated with urethritis, conjunctivitis, or mouth ulcers, just pick reactive arthritis. So if you're thinking it could be it, it's probably it. Synovial fluid analysis is usually sterile, and the treatment here is NSAIDs. Those are first line during any kind of attack. The other kind of arthritis is an enteropathic arthritis. This is a little lower yield, but it's higher yield more towards the ulcerative colitis and Crohn's disease aspect. So it's only seen in 10 to 20% of patients, but only in those patients with ulcerative colitis and Crohn's disease. So we'd have to be thinking more along the lines of one of those diseases in GI to then be associated with enteropathic arthritis. So the lower extremities and the sacroiliac joints are going to be mainly involved, and the symptoms, they come and go, wax and wane, with symptoms of bowel diseases. And these patients are going to have prominent GI symptoms and other extraintestinal manifestations. So a P-ANCA may be present in ulcerative colitis and in ankylosing spondylitis, despite having an absence of a vasculitis. So remember P-ANCA for patients. All right, next up we have ye old rheumatoid arthritis, right? And these are clinically, the presentation is going to be insidious in onset, multiple joint pain, stiffness and swelling. There's going to be morning stiffness that lasts for hours and improves with activity. The smaller joints are going to be involved, so like the PIPs, the MCPs, and the MTPs, metatarsophalangeals, those are commonly involved. Monoarthritis is, again, also like the knees and the elbows can occur, but later on. But what you need to know about rheumatoid arthritis is that it spares the distal interphalangeal joints. So this is more of metacarpal phalangeal, proximal interphalangeal, but not the distal interphalangeal. The distal interphalangeals are reserved for osteoarthritis, right? For proximal, it's rheumatoid arthritis. All right. On examination, the affected joints are going to be tender to the touch. That's going to be painful. Swollen. There's going to be limited range of motion. Also, trigger fingers is a tenosynovitis of the palm that can lead to like a trigger finger, and rheumatoid nodules, especially on the elbow. Okay, so there's a couple of elbow associations with nodules, syphilis being one of them, rheumatoid nodules being another. There's a cervical joint involvement that can lead to spine subluxation, specifically spinal cord compression as well with rheumatoid arthritis. On labs and on imaging studies, a positive anti-CCP antibody is the diagnostic test of choice. So anti-CCP antibodies. I know it sounds like Russian. So anyway, Russian rheumatoid anti-CCP. I don't know. Nothing against Russia or anything. It just sounds like it. There's a high IgM rheumatoid factor as well, and high C-reactive protein and ESR that correlates with disease activity. On x-rays, there's a soft tissue swelling. There's going to be joint space narrowing as well as bony erosions. That anti-CCP, by the way, that's anti-cyclic citrullonated peptides. I don't know why it just wasn't ringing in my head at first glance, but anti-CCP is anti-cyclic citrullonated peptide associated with rheumatoid arthritis. Kind of just a refresher from step 1. But you'll be amazed at how these step 1 associations are going to help you out so much for step 2 and for step 3 as well. So peak incidence at 50 to 75 years of age. That's when they get it. There's a reduced grip strength that can occur occasionally, and that's a sensitive sign for early disease. Remember, it affects the proximal interphalangeals, so they're going to have a problem with gripping. Osteoporosis causes an increases in pro-inflammatory cytokines, corticosteroid therapy, and the lack of physical activity. That's going to cause like a localized inflamed joint and a generalized loss of bone mass, like an increased risk of osteopenia, osteoporosis, as well as bone fractures, especially if the risk factors like low body weight, a female sex, smoking, or a family history of osteoporosis, postmenopausal states, excessive alcohol intake, or other comorbidities are present. So the degree of bone loss is going to correlate with the disease activity. So the more the bone loss is, the higher the disease activity, right? So let me go over those risk factors again, since I went over them kind of fast. So they can have a risk of osteopenia, osteoporosis, and bone fractures. And those bone fractures are especially at even higher risk if the patient has low body weight, if they're females, if they smoke, if they have a family history of osteoporosis, if they're postmenopausal, if they're excessive alcohol drinkers, or if they have any other comorbidities. All right, and then the strategies to prevent bone loss is going to be adequate physical activity, and you want to optimize vitamin D and calcium intake and minimize the doses of steroids. There's a low threshold for starting bisphosphonates in rheumatoid arthritis patients, by the way. So on x-ray, there's long-standing poorly controlled disease. This is going to show up as a periarticular osteoporosis with joint erosions as well as joint space narrowing. In the eye, there can be episcleritis, and that's an inflammation seen on that white portion of the eye that doesn't involve the uveal tract. And that's strongly associated with rheumatoid arthritis as well as inflammatory bowel disease, episcleritis. Look at a picture of that, it's kind of impressive. So how do you treat rheumatoid arthritis? There's a little algorithm here. So let's go through it really quick. There's if you have rheumatoid arthritis, the first thing you want to give them is methotrexate. And if the symptoms improve, or if they have persistent symptoms for more than 6 months, you can either parallel that therapy with another non-biological agent like sulfasalazine or hydrochloroquine, or you can do a step-up therapy, like you can add a biological agent like TNF inhibitors. If there's a good response to that, just leave it. If it's not, if there's not an adequate response, then you want to switch to an alternative TNF inhibitor, but you want to continue methotrexate. You want to start DMARDs ASAP, right? And because the joint damage begins very early on the course. Methotrexate is preferred initially as a DMARD in moderate to severe rheumatoid arthritis, and that's due to the efficacy and long-term safety profile of methotrexate. But before you give methotrexate, remember you need to test for TB, hepatitis B virus, and hepatitis C virus. So that's a big one. They love to ask. Prevention. Check TB, hepatitis B, or hepatitis C virus before giving methotrexate. What are some of the contraindications to giving methotrexate if the patient is pregnant and those who are planning to become pregnant in the near future. That's contraindication. Also severe renal insufficiency, and liver disease, or excessive alcohol intake. Those are big time contraindications to giving methotrexate. NSAID and COX-2 inhibitors, these are adjunctive therapies for symptomatic relief, but they don't reduce progression. They're for symptomatic symptom relief, NSAIDs and COX-2 inhibitors. And then steroids, those can relieve the symptoms short term, but they're not effective in preventing the eventual joint destruction. So what is the best treatment for rheumatoid arthritis? Methotrexate. And watch out if they're pregnant or they're planning to become pregnant, or if they have renal insufficiency, if they're drinkers, they have liver disease, and you cannot give methotrexate to somebody who has TB, hepatitis B virus, or C virus. Emphasizing that a lot because that's what they really ask you for. All right, next up is Feltes syndrome. So what's Feltes syndrome? This is a clinical disorder seen in patients with severe long-standing rheumatoid arthritis. So rheumatoid arthritis that's been going on for more than 10 years, but it rarely precedes the diagnosis. It's characterized by neutropenia as well as splenomegaly. And the splenomegaly is going to be without neutropenia. Those can occur in patients with rheumatoid arthritis, but that diagnosis of Feltes syndrome should not be made in the absence of neutropenia, right? So you shouldn't diagnose Feltes syndrome if there's no neutropenia. So neutropenia is, that's the characterization of Feltes syndrome. So neutropenia and splenomegaly. If they don't have neutropenia, that's probably not Feltes syndrome. So patients with Feltes syndrome have severe seropositive rheumatoid arthritis with an increased risk of extra-articular manifestations. And it's more common in women. The peak incidence is in the 4th and 5th decade of life. The pathophysiology really isn't known, and but it is associated with the HLA-DR4. And there's an increased risk or increased incidence, in patients with a family history of rheumatoid arthritis. So if there's any kind of rheumatoid arthritis in the family and suddenly they're coming in and you check out on labs, they have severe neutropenia, splenomegaly, think of Feltes syndrome, right? Also if they have some kind of long-standing rheumatoid arthritis, obviously. Also, Feltes syndrome usually improves with treatment of the underlying rheumatoid arthritis. So it's almost like a rheumatoid arthritis plus. So the patient has rheumatoid arthritis for a very long time, more than 10 years. You check their labs, they get severe neutropenia. What's the diagnosis now? It's Feltes syndrome, and that's the diagnosis. It's just a rheumatoid arthritis plus. How do you treat it? Well, you got to treat the rheumatoid arthritis and the Feltes syndrome goes away. So methotrexate. So a little recap here. Features of Feltes syndrome. You have rheumatoid arthritis. So the patient has severe erosive joint disease and deformities. Rheumatoid nodules. Remember those elbows? They like to ask that because it trips you up. Vasculitises like mononeuritis, multiplex, and necrotizing skin lesions. Big time is the splenomegaly, and big time is the neutropenia, an absolute neutrophil count, specifically less than 1,500. And you're thinking Feltes. The diagnosis is made with the anti-CCP and rheumatoid factor positivity. So that's positive in more than 90% of patients. They're going to have a markedly elevated ESR, often more than 85, and a peripheral smear and bone marrow biopsy is done to rule out other causes of neutropenia. So it's almost like a diagnosis of exclusion in a way. You kind of have to find out, okay, so this patient has rheumatoid arthritis. It's been going on for more than 10 years. He has splenomegaly. He does have neutropenia, but before we diagnose Feltes syndrome, let's make sure that it's not caused by some kind of infection, right? So you need to do the smear, you need to do a bone marrow biopsy to rule out any other causes of that neutropenia. Once everything is ruled out, then you can diagnose Feltes syndrome. All right, moving on from Feltes syndrome, we have osteoarthritis. And osteoarthritis risk factors would be if the patient's older than 50, obese patients, prior joint injury, and diabetes as well. those are all risk factors for osteoarthritis. On history, the symptoms would be chronic symptoms or insidious onset symptoms. There can be minimal or no morning stiffness. And remember that prolonged rest can actually cause stiffness and pain, but it's usually worse with activity. For a physical exam, the knees and the hips are seen, the distal interphalangeal joints, cervical and lumbar spines. Those are all done with physical exam. You'll also feel hard bony enlargements of the joints and crepitus with movement. That's a big one. Radiology, the x-rays are going to show narrowed joint spaces, osteophytes, and subchondral sclerosis, but the diagnosis is usually clinical, right? X-rays confirm the diagnosis. Arthrocentesis is sometimes performed, and if that's done, it's going to show clear fluid without any type of inflammatory cells. So next up, we have hip osteoarthritis. So you have here pain in the groin or the buttocks or in the pelvis, and that can radiate to the lower thigh or to the knee. This is a hip osteoarthritis. There's going to be a decrease in external and internal rotation, but synovitis is going to be absent. So synovitis would be like redness, warmth, and tenderness. That's just all going to be absent with hip osteoarthritis. So how do you manage hip osteoarthritis? First of all, non-pharmacological treatment is always first line. So what do you mean by that? Is by exercise or by weight loss. If the symptoms persist, then you can go on and tell them, hey, you can have NSAIDs as needed, or alternatively, they can take acetaminophen. However, if the symptoms persist even doing so, then you can start doing NSAIDs and capsaicin. So these are topical NSAIDs and capsaicin, or intra-articular steroids, as well as intra-articular hyaluronic acids. So if these topical or intra-articular medications don't do anything and the symptoms persist with causing significant impairment at this time, then surgery is going to be your last option if possible. And non-surgical candidates can have chronic pain management, such as with all the other, within like an opioid or more steroids. NSAIDs are going to relieve the pain, but they don't alter the progression of the disease. That's another thing to keep in mind. So it's not going to help you get better. It's just going to relieve the pain. All right, next up we have lupus, SLE, and this is mainly going to be seen in young African Americans, Hispanics, and Asian women. Those are the greatest risk factors. So if you see any of those, especially young African Americans, start thinking of SLE, lupus. So what are the manifestations of lupus? So clinically, symptoms would be like constitutional symptoms such as fever, fatigue, and weight loss. They can also have symmetric migratory arthritis. On the skin, you'll see the butterfly rash and photosensitivity. Serositis can be seen, or not seen, can be a symptom. So pleurisy, pericarditis, and peritonitis. Thromboembolic events due to the vasculitises and antiphospholipid antibodies. We'll see that in a little bit. Neurological problems would be like cognitive dysfunction as well as seizures. This can also cause strokes and headaches due to the vasculitises. On labs, with lupus, you'll see a hemolytic anemia or thrombocytopenia and leukopenia. Also, complement levels will be low, so C3 and C4 will be low. And antibodies the antibodies that are sensitive would be like ANA, and the specific ones are your anti-double-stranded DNAs and anti-Smiths or anti-SM. Those are pretty much standard UWorld and Step 1 questions that have transferred over to Step 2 CK. So remember, ANA is sensitive, anti-double-stranded DNA, anti-Smith is specific. All right, renal involvement. Obviously, you're going to have proteinuria, and it can also lead to an elevated in creatinine. Hematological manifestations of lupus, it can cause anemia, it can cause leukopenia, and it can cause thrombocytopenia. So some of the common mechanisms with anemia would be anemia of chronic disease, renal insufficiency from lupus nephritis. There could be an iron deficiency anemia due to the GI loss. Remember, GI loss due to maybe peptic ulcer formation from constantly taking NSAIDs. That's a stretch, but that is a common mechanism, as well as autoimmune hemolytic anemias. Uncommon mechanisms of anemia would be like medications, or direct causes of medications, because NSAIDs is like an indirect cause. Medications specifically causing anemia is uncommon. Hypersplenism, microangiopathic hemolytic anemia, as well as aplastic anemia. Those are all uncommon mechanisms. For leukopenia, the common mechanisms would be autoimmune mediated destruction, and uncommon mechanisms of leukopenia would be medications, again, hypersplenism, and bone marrow dysfunction. Common mechanisms of thrombocytopenia would be immune mediated destruction. And uncommon mechanisms, again, would be medications, again, increased consumption due to thrombotic microangiopathy, and that would be like a TTP, for instance. So medications are all uncommon mechanisms for anemia, leukopenia, or thrombocytopenia. Lupus can cause pancytopenia due to concurrent immune-mediated destruction of all the 3 cell lines, and bone marrow suppression can also cause a pancytopenia. So, however, this is not usually due to lupus, but it's due to other coincidental conditions, so like leukemia, like drugs, myelodysplasia, and malignant invasion of bone marrow can all cause it. As a result, then the bone marrow biopsy is frequently going to be done in lupus patients, and that's done to exclude other causes. Some of the renal manifestations of lupus would be immune complexes that are composed of double-stranded DNA and anti-double-stranded DNA antibodies. Those are going to deposit in the mesangium and or the subendothelial space. Because that happens and start accumulating, it causes an intense inflammatory response and increased complement activation. So this is why you get, in essence, you'll get later on lower C3 and C4 levels, as well as a nephritic syndrome. So it's kind of like they're getting used up very quickly because of the inflammatory processes. The immune complexes can also deposit in the subendothelial space, and whenever that happens, you're going to get a membranous glomerulonephritis. So remember, the nephron within the glomerulus, right? Glomerulonephritis is an itis, an inflammation. And if you're talking about the membranous layer, then the membranous layer all the way on the bottom is that these deposits have to go into the subendothelial space to cause membranous glomerulonephritis. That's it's a little thing that I used to think about to learn this. I'm pretty sure everybody already knows this, but why not? All right, so a nephrotic syndrome without hypocomplementemia can be basically the end result of a renal manifestation of lupus. So clinical features would be fatigue, painless oral ulcers, non-deforming arthritis, renal abnormalities like hematuria or proteinuria, and glomerulonephritis. Cytopenias are most common manifestations of the active disease, as the cytopenias. Also, other clinical features like morning stiffness are much shorter than in rheumatoid arthritis. Both rheumatoid arthritis and lupus can both cause morning stiffness, but the actual duration is shorter in lupus than in rheumatoid arthritis. So how you screen: initial screening and initial evaluation in a patient suspected of having lupus. You should do a blood count to look for cytopenias. You need to do a urine analysis and also creatinine to screen for any kind of nephropathy. That's obvious. Then ANA titers are obtained early on, but remember the ANA or ANA is sensitive. If those are positive, then you're going to want to confirm with something more specific. So you want to confirm with, remember, anti-double-stranded DNA or anti-Smith antibodies. And many patients will be negative for these even in the absence of multiple system involvement. So just because they're negative for specific markers doesn't necessarily mean that they're free and clear. So complement levels, ESR, and C-reactive protein should also be done but mainly these are going to be done to assess disease activity. So if the disease activity is going well, then those levels will be a little bit on the normal side. ESR and CRP won't be as high. Got it? So so then monitoring disease activity in lupus, you would need periodic blood counts, inflammatory markers like the ESR, like we said, as well as complement levels and anti-double-stranded DNA titers. Regularly screening for lupus nephritis and with a urine analysis, serum creatinine, and a protein assay. Sorry. Okay, now treatment. The choice of drug is going to depend on the degree of organ involvement, and most patients with active lupus are going to benefit from hydroxychloroquine, which is a safe and well-tolerated medication. So the hydroxychloroquine can cause retinal toxicity, but that's rarely leading to an irreversible vision loss. So just because it causes retinal toxicity doesn't necessarily mean it's going to cause an irreversible vision loss. That's rare, but it's a retinal toxicity is a common manifestation of hydroxychloroquine. And then common after 5 to 7 years of therapy. So if that's the case, you want to perform a baseline ophthalmological evaluation with an annual reassessment starting after 5 years. So whenever you're taking hydroxychloroquine or need to start taking hydroxychloroquine whatever, if the vignette starts telling you that the patient may require hydroxychloroquine, which of the following is needed before administering the medication, and it would probably be a baseline ophthalmological evaluation. All right, so cyclophosphamide, that's going to be reserved for patients with significant renal or CNS involvement. It can cause acute hemorrhagic cystitis, however. Remember that cyclophosphamide, you remember back in UWorld First Aid Step 1, there was the chemotoxman, and the cyclophosphamide looked like was in the bladder area, right? So hemorrhagic cystitis, cyclophosphamide. It can also cause bladder cancer and sterility, and as well as myelosuppression. So I would recommend going over that chemotoxman if possible on first aid. It's going to be there, Google it or whatever. It's going to help you on this exam as well. Acrolein is the bladder toxic metabolite of cyclophosphamide. It's called acrolein. So not like you need to know that, but whatever. You need to drink plenty of water when you're on cyclophosphamide and void frequently, and then take Mesna to prevent renal complications of cyclophosphamide. So remember the Mesna connection. Drink plenty of waters. It causes hemorrhagic cystitis, bladder cancer, sterility, myelosuppression, and remember for hydroxychloroquine that they need to perform a baseline ophthalmological evaluation because it can cause retinal toxicity. Okay, next up we have antiphospholipid syndrome, which is another manifestation of lupus. Clinical features would be like venous and arterial thromboembolic diseases. So here you would have patients that have DVTs, pulmonary embolisms, and ischemic strokes and transient ischemic attacks. The big one with antiphospholipid antibody syndrome would be adverse pregnancy outcomes. So here we'll have unexplained embryonic or fetal loss, premature birth due to placental insufficiency or preeclampsia. So they're constantly clotting that placenta, causing thrombi in that placenta, and you're going to have a patient with recurrent abortions. For lab findings in antiphospholipid syndrome, you have lupus anticoagulant effects with a paradoxical PTT prolongation, and that's your thrombocytopenia. And it's not reversed when you do a plasma mixing study, so that's a big one. Remember with the mixing study, you add normal plasma to the patient's normal plasma, and when you do the labs later on, it should level out. But in a lupus, you have a lupus anticoagulant within you, so even if you put in the plasma mixing study, it's not going to reverse it. So that's a good one to remember. And also the presence of specific antiphospholipid antibodies, so specifically like anticardiolipin antibody, and another one called anti-beta-2 glycoprotein 1 antibody. Remember, all those are connected with antiphospholipid antibody syndrome. All right, so the diagnostic criteria for antiphospholipid antibody syndrome would be 1 clinical criteria and 1 laboratory criteria. Those are the minimum that must be met. So clinical criteria, you have like vascular thromboses and pregnant morbidities. So for vascular thrombosis, it would be like AV thromboses. And for pregnancy morbidity, more than 3 consecutive unexplained fetal losses before the 10th week of pregnancy should raise your eyebrow for lupus. More than 1 unexplained fetal loss after the 10th week, or more than 1 premature birth of a normal neonate before the 34th week due to either preeclampsia, eclampsia, or placental insufficiencies. And that's due to that microclotting, right? Laboratory-wise, the laboratory criteria would be the lupus anticoagulant or an anticardiolipin antibody, which is IgG, IgM, medium or high titers, or that anti-beta-2 glycoprotein 1 antibody, which is a high titer of IgG, IgM. If you have either one of those on labs with any of the pregnancy complications or vascular thrombosis, then that meets the criteria for antiphospholipid antibody syndrome. How would you diagnose? Vascular thrombosis is a transient ischemic attack or stroke with DVTs and or pregnancy complications with recurrent miscarriages, plus more than one of the following. It was the anticardiolipin antibody, lupus anticoagulant, and that beta-2 and glycoprotein antibody. It's kind of I'm just going through this a little bit quicker because it's kind of reiterating the same thing that we just talked about. The 1 clinical, 1 laboratory necessity. And the management here is to anticoagulate them. So how would you do so? Either with heparin or warfarin, that heparin-warfarin bridge. And some healthy patients may transiently become positive for antiphospholipid syndrome antibodies. So all patients that are positive for those antibodies should get repeat tests for antibodies after 12 weeks to confirm the diagnosis. The biggest risk factor for antiphospholipid syndrome is going to be lupus in 40% of cases with lupus, but it can occur independently of lupus. So just because you don't have lupus doesn't necessarily mean you can't have antiphospholipid syndrome. It occurs independently. So antiphospholipid syndrome is associated, antibodies can mediate a hypercoagulable state, and that can cause placental thromboses. And potential complications are going to include recurrent first trimester miscarriages, fetal demise, preeclampsia, fetal growth restrictions, prematurity, so like the ones that we just mentioned. The treatment, patients with antiphospholipid syndrome require anticoagulation with low molecular weight heparin and low dose aspirin after an acute thrombotic event, or to prevent pregnancy loss, or to prevent a venothromboembolism during a pregnancy. And patients require long-term treatment with warfarin. You want to also add hydroxychloroquine in patients that have concomitant lupus. So if they have lupus and they have antiphospholipid syndrome, consider low molecular weight heparin, aspirin, plus throw in that hydroxychloroquine. A false positive RPR-VDRL is very common in antiphospholipid syndrome, as syphilis antigens are used in RPR that contains cardiolipin. So that's important. Syphilis antiphospholipid syndrome bridge there is that false positive RPR-VDRL. Okay, and then DMARDs. Some of the DMARD classifications you have, DMARDs are divided into non-biological agents and biological agents. So under non-biological agents are small molecule drugs produced by conventional chemical syntheses. And these are going to target inflammatory pathways like sulfasalazine is an example, hydroxychloroquine, methotrexate, leflunomide, and azathioprine. Those are all non-biological agents that are small molecule drugs. Now, large molecule drugs, these are biological agents, and those are produced primarily with recombinant DNA technology. These are going to target cytokines and cell surface proteins. Here we have like TNF inhibitors like etanercept, infliximab, adalimumab, and tocilizumab, also rituximab as well. So those are their biological ones, which are large. Non-biological are small. All right. So DMARDs, the agents. So like we've already mentioned, but we're going to go into specific mechanisms and adverse effects, which is what they really ask you, is those adverse effects. So for methotrexate, we already know that methotrexate is a purine antimetabolite, but what they like to ask is that it causes hepatotoxicity, it can cause stomatitis, and it can cause cytopenias. Leflunomide, this one is a pyrimidine synthesis inhibitor, and this can cause hepatotoxicity as well, and also it can cause cytopenias. Hydroxychloroquine, that one's associated with retinopathy, and its mechanism is that it's a TNF and IL-1 suppressor. Sulfasalazine is also a TNF alpha or TNF and IL-1 suppressor, but that one also can cause hepatotoxicity, stomatitis, and a hemolytic anemia. So for sulfasalazine. And then you have your bunch of TNF inhibitors such as adalimumab, certolizumab, etanercept, golimumab, there's a lot of mabs, sorry, and infliximab. And adverse effects of all these TNF inhibitors would be like infection, demyelination, congestive heart failure, and malignancy. All right, moving on, we have Raynaud's phenomenon. So there's two types of Raynaud's. There's primary Raynaud's and there's secondary Raynaud's. So primary Raynaud's, the etiology is unknown. There's no underlying cause. Clinically, patients with primary Raynaud's syndrome is usually women that are younger than 30 years of age with no tissue injury, and they're negative for ANA, and they have negative ESR. So it's kind of odd there. It's just a young woman with really nothing. And the management is to avoid any kind of aggravating factors, and if they get any type of symptoms, you want to give them calcium channel blockers. So that's primary Raynaud's phenomenon. Okay, now secondary Raynaud's, this is a little bit more complete here. So we have the etiologies here are a little bit more known. So you have connective tissue diseases can cause it, occlusive vascular conditions, sympathomimetic drugs, vibrating tools, okay, like jackhammers and stuff. Don't get weird. Hyperviscosity syndromes, as well as nicotine. And then clinical presentations of secondary Raynaud's phenomenon would be in men. So it's usually seen in men greater than 40. And the symptoms of the underlying disease can be seen: tissue injury with or digital ulcers, and abnormal nail fold capillary examinations. These would be your dilated or dropout vessels in the nail fold capillaries. And that's predictive of future developments or the presence of disease, right? And then how would you manage secondary Raynaud's? Here you would manage with evaluating and treating the underlying disorder. You can also give them calcium channel blockers if they get persistent symptoms, because remember, this is all spasmodic, right? You can give them aspirin for patients at risk for digital ulcerations. Dihydropyridine calcium channel blockers like amlodipine and nifedipine, these are the ones that are going to be used. So when they say CCBs, specifically it's your dihydropyridine, amlodipine and nifedipine. So primary Raynaud's phenomenon, like we saw, that's the young woman with factors there, are going to increase vascular responses to cold and emotional stress, right? These are asymmetrical episodic attacks, and the episodes can involve tingling, numbness, pain with color changes and pallor. Those are your white attacks. And then the cyanosis, if that cyanosis is involved, that's your blue attack. Whatever. The treatment here would be a smoking cessation and avoidance of cold temperatures and emotional stress. Because remember, we don't know the reasoning behind primary Raynaud's. And pharmacological therapy includes dihydropteridine calcium channel blockers like nifedipine or amlodipine. For secondary Raynaud's, this is going to be based on the history of physical examinations. Workup for the patient with suspected secondary Raynaud's is going to require you to do like CBCs with a metabolic panel, urine analysis, antinuclear antibodies and rheumatoid factors, ESR and complement levels, so C3 and C4, and if ANA is positive, specific antibodies can be obtained. All right, so next up we have systemic sclerosis. And for systemic sclerosis, we're going to go through the clinical features. So systemic features, skin features, vascular, GI, pulmonary, renal, and cardiac. So for systemic symptoms of systemic sclerosis is fatigue and joint stiffness as well as pain. Okay, that's systemically, that's what you're going to find. On the skin is going to be telangiectasias as well as sclerodactyly, digital ulcers, and calcinosis cutis. Vascular will be your Raynaud's phenomenon for systemic sclerosis. GI features are going to be dysphagia, dyspepsia. And remember, that's going to affect the esophagus, leading to smooth muscle atrophy and fibrosis in the lower esophagus. And because of that, patients are going to get like choking, hoarseness, and on esophageal manometry is going to show hypomobility and incomplete closure of the lower esophageal sphincter. That's why they get dysphagia and dyspepsia with systemic sclerosis. Also, there's angiodysplasia of the stomach. They got that watermelon stomach with a GI bleeding. And then malabsorption is also due to bacterial overgrowth. For pulmonary causes, pulmonary fibrosis, pulmonary complications are going to be the most common cause of death in systemic sclerosis. 40% of cases are going to be due to diffuse systemic sclerosis. That's the most common complication of systemic sclerosis is pulmonary problems. So pulmonary fibrosis and pulmonary arterial hypertension as well. And remember, because of that, that can also lead to a right heart failure. Renal causes would be like sclerodermal renal crises, acute onset of oliguric renal failure with malignant hypertension. Before we had ACE inhibitors, renal crises led to more hypertension. That used to be the most common cause of death, but because we use ACE inhibitors now, renal causes are not as common. Also, thrombocytopenias to the kidneys and microangiopathic hemolytic anemia. And then cardiac would be like myocarditis, pericarditis, and pericardial effusions. Those are all cardiac causes of systemic sclerosis. So extreme heterogeneity in manifestations and severity for systemic sclerosis. Some degree of skin involvement is seen in almost all of the cases. So if they tell you about the skin, it's not really going to tell you much other than that they're talking about systemic sclerosis. It's probably not going to be an answer choice. It's just a train of thought to lead you into that diagnosis. Limited systemic sclerosis is going to be limited to the skin of the wrists, the hands, and the face. It could have esophageal dysmotility and vascular symptoms like Raynaud's, but extradermal manifestations are limited in most cases. Whereas you have diffuse cutaneous systemic sclerosis with dermal thickening involving the proximal extremities or the trunk is more likely to cause extradermal manifestations and carries a more severe prognosis for diffuse. Even if I didn't know that, diffuse sounds more severe than limited, right? If it's limited to something, then how severe can it be? Unless it's like your brain or your heart. Anyway, and then antibodies, ANA in all patients, anti-topoisomerase 1 antibodies in diffuse scleroderma, and anti-centromere antibodies in limited scleroderma. So let me read that again because that's very high yield. So the antibodies are going to be ANA in all patients, anti-topoisomerase 1 antibodies in diffuse scleroderma. And for limited is going to be your anti-centromere antibodies. Okay, so moving on, we have Sjogren's syndrome. And in Sjogren's syndrome, this is seen more in females in the 5th or 6th decades of life. Okay, so 50s, 60s, stuff like that. So primary symptoms, there's no associated connective tissue disease in Sjogren's syndrome. Secondary Sjogren's syndrome is going to be your comorbid connective tissue disease, so like lupus, rheumatoid arthritis, and scleroderma. Clinical features of Sjogren's would be ocular symptoms like dry eyes, decrease in tears. Oral symptoms would be like dry mouth, swollen salivary glands. Objective signs would be like decreased lacrimation. Autoantibodies to Rho, which is SSA, or LA, SSB. That's a big one. The autoantibodies, Rho or LA, SSA, SSB. Then salivary gland biopsy is done with focal lymphocytic sialodenitis. Enlargement and firmness to palpation of those glands are going to be seen. And then salivary gland involvement, like a decreased salivary flow, a delayed uptake in the salivary scintigraphy. So extra glandular manifestations are going to include like arthritis, Raynaud's phenomenon, or vasculitis. And occasionally, optic neuritis can be present. Other antibodies that can be present are going to be ANA. ANA is pretty much present in almost all those antibodies, autoantibodies. And then rheumatoid factor as well. And the diagnosis is going to be confirmed by a subjective or an objective evidence of dry mouth, dry eyes, and in the presence of either histological presences of lymphocytic infiltrations of those salivary glands and serum antibodies that are directed against SSA or SSB, Rho or LA. So all I remember about Sjogren's is somebody who has dry skin, dry eyes, is always thirsty, and dry skin, has autoantibodies present, and they have the autoantibodies to SSA, SSB, Rho, or LA. If you can remember those, which I'm sure you all do, you'll be good. All right, moving on, we have paraneoplastic syndrome. So for paraneoplastic syndrome, it's going to be divided into a couple of diseases here. We have myasthenia gravis, Lambert-Eaton syndrome, and we also have dermatomyositis, polymyositis. So for myasthenia gravis, the involved site is acetylcholine receptors in the postsynaptic membrane. Clinical features would be like fluctuating muscle weakness, as well as ocular ptosis and diplopia, and bulbar features would be dysphagia and dysarthria, as well as facial, neck, and limb muscles. So those are all associated with affected features of myasthenia gravis. For Lambert-Eaton syndrome, this is located in the presynaptic membrane. So these are voltage-gated calcium channels, the presynaptic ones. So here, features would be like proximal muscle weakness, and the muscle weakness and the deep tendon reflexes, these are going to improve with repetitive isometric contractions. So that's the distinguishing feature between Lambert-Eaton and myasthenia gravis, is that Lambert-Eaton is going to improve with contraction, with repetitive movements, versus myasthenia gravis will be worse, right? And then finally, we have dermatomyositis, polymyositis, and this is specifically an injury to the muscle fibers. And the clinical symptoms here, clinical features, would be symmetrical and proximal muscle weakness. There's also interstitial lung disease, esophageal dysmotility. There could be Raynaud's phenomenon and polyarthritis. Patients can also have esophageal dysmotility as well, and skin findings will be the rashes, right? For the dermato part would be like Gauthrin's papules, and the heliotropic rash. So that would be the skin findings in dermatomyositis. So paraneoplastic syndromes, these are common when there's lung cancer involved, ovarian cancers, breast cancers, and lymphomas. So all those cancers can have paraneoplastic syndromes. So now, what is the differential diagnosis of myopathies, right? So there's several disorders like steroid-induced myopathy, there's polymyalgia rheumatica, inflammatory myopathies, there's statin-induced myopathies, and there's hypothyroid myopathy. So clinically, glucocorticoid-induced myopathies, these are going to have progressive proximal muscle weakness, and there's going to be atrophy, but obviously without pain or tenderness. Go figure, you're steroid-induced, so there's really not going to be a lot of pain there, but there's going to be proximal muscle weakness. And the lower extremity muscles are mostly going to be the ones involved in the lower extremities. The ESR and the CK, again, are going to be normal because this is a steroid, right? It's steroid-induced. Now, polymyalgia rheumatica, these patients are going to have muscle pain and stiffness in the shoulders and the pelvic girdle. They're going to also have tenderness and decreased range of motion at the shoulder and the hip girdle, so the neck and the hip. And they're going to respond rapidly to steroids. Because these polymyalgia rheumatica isn't involved with steroids, here the ESR is going to be increased, but the CK is going to be normal because there's no muscle involvement here. It's just muscle pain and stiffness, so the CK is fine. In inflammatory myopathies, now you're going to have CK involvement as well as an increase in ESR. So patients are going to have muscle pain, tenderness, and proximal muscle weakness. And for inflammatory myopathies, they can also present with a skin rash and inflammatory arthritis. So be careful with that and polymyalgia rheumatica. A good way to remember these two is that in polymyalgia rheumatica, the CK is normal versus an inflammatory myopathy, the CK is increased. All right. Then we have statin-induced myopathies. I think that's pretty easy to remember. Statins is the most important, not the most important, but the most common thought of answer would be muscle involvement, right? So proximal muscle weakness, pain and tenderness, and also rarely statins can cause rhabdomyolysis. Here the ESR is going to be normal, but the CK is going to be elevated. And finally, hypothyroid myopathy, it's pretty easy to remember because they do have features of hypothyroidism, but they can have delayed tendon reflexes. They can have muscle pain, cramps, and weaknesses in the proximal muscle. And again, the ESR is normal, but the CK is increased. So let's talk about steroid-induced myopathy or glucocorticoid-induced myopathy. It's an acute myopathy that is associated with high-dose steroids in critically ill patients, and it's less common than chronic myopathies. There's an increase in muscle catabolism and a decrease in anabolism as a direct effect of the steroids. So the risk of glucocorticoid-induced myopathy increases when you get higher doses of steroids. Generally, we're talking more than 40 milligrams of steroids daily. When you're at those high levels, there's a risk of steroid-induced myopathy. So muscle power increases after you discontinue the medication, but the recovery does take weeks to months. So that one's pretty easy to remember. All right, moving on, we have fibromyalgia versus polymyositis versus polymyalgia rheumatica. So in fibromyalgia, some of the distinguishing clinical features is usually going to be a young to middle-aged woman with widespread musculoskeletal pain in both sides of her body, above and below the waist. So here it's just pain everywhere. Fatigue when arising from sleep and in the mid-afternoon. They also have cognitive difficulties like attention or tasks that require rapid thought changes. They'll have difficulty doing those things, as well as nonspecific GI symptoms. So they'll complain of like diarrhea or constipation. So in labs, there's no abnormal lab results, They're possibly going to have tender points on physical examination, and most likely that's the way they're going to ask you, specifically around the trapezius, the lateral epicondyle, the costochondral junction, as well as the greater trochanter. So, everywhere you're able to palpate, they might have some pain there. The symptoms are more than 3 months, and they also have increased widespread pain index or symptom severity score. So think of a young to middle-aged woman with widespread pain of her body, non-specific GI symptoms, and possible tender points when you palpate. Fibromyalgia. All right. Now, polymyositis, this is symmetrical proximal muscle weakness. They have increasing difficulty climbing stairs, getting up from a chair, combing their hair, everything that rhymes, and carrying heavy groceries. It's less prominent in the hip or the shoulder. So the hip and the shoulder is not going to be affected as much with polymyositis. Here it's more like upper extremities, but it's going to be symmetrical proximal muscle weakness. On labs, you'll see elevated muscle enzymes, so look for creatinine kinase, aldolase, lactate dehydrogenase, as well as aspartate aminotransferase. And possibly there'll also be an increase in autoantibodies, and when you do an electromyography, that's going to come back abnormal. For polymyalgia rheumatica, here the patients are going to be greater than 50 years of age. They're going to complain of aching and morning stiffness, and then that morning stiffness is going to be greater than pain in the shoulders, the hips, the neck, and the torso. But they can also have those things as well. It's going to be aching more than painful, and it's going to present more in the morning with stiffness. Also synovitis, bursitis, and decreased range of motion with no significant muscle tenderness, and possibly they can even acquire systemic symptoms. For labs and how you diagnose this, the diagnosis is made clinically, and they're also going to have significantly elevated ESR rates. The symptoms do improve with steroids, however. So that was for polymyalgia rheumatica, more than 50 years of age. Okay, now let's go in a little bit more detail on fibromyalgia really quickly. So the diagnosis, the best thing to do is a history and a physical exam findings. And on the 2010 American College of Rheumatology criteria, it suggests that using a widespread pain index and symptom severity score rather than trigger points is going to be used for the diagnosis of fibromyalgia. So before, like 10 years ago, it was more of those tender trigger points, and that's how you diagnose it. Now it's a widespread pain index to be able to diagnose fibromyalgia. They better address the cognitive problems and the fatigue, as well as the severity of the symptoms. All right, so let's talk a little bit more about the widespread pain index. So this widespread pain index is a score between 0 to 19, and it's going to deal with like the neck, the jaw, the shoulders, the arms, lower arms, chest, abdomen, the upper and lower backs, the hips, and the upper and lower legs, and obviously the left and the right of those extremities. And then the symptom severity, you just basically add them up using this symptom severity scale. So 0, 1, 2, and 3. So 0 meaning no problem, 1 meaning that there's a slight problem, 2 moderate, and 3 severe. Okay, so you just start adding up those numbers per group, or per extremity, per parts of the body, and it should give you a final score between 0 to 12. So the diagnosis really is going to depend on the tenderness in at least 11 of the 18 defined trigger sites. So treatment. The initial fibromyalgia treatment is going to emphasize on patient education. So like fibromyalgia is a benign condition that has a favorable prognosis. So regular aerobic exercise as well as good sleep hygiene is always a good recommendation. Patients are going to perceive that their pain and fatigue are worse acutely during or after an exercise. Like if they actually took your advice, went to the gym, started doing aerobic exercise or strength training and stretching, they can actually start complaining about their pain and fatigue that's worsened acutely during or after the exercise. You just got to keep emphasizing that in the long run, it'll better them. So gradual and incremental low impact exercises would be maybe better suited for these patients, like swimming or walking, fast walking, or water aerobics. These improve the pain and fatigue and also improve the long-term benefits because you're still exercising. Specifically, water exercises can greatly reduce the pain. Patients who don't respond to conservative measures may require medications like TCAs, for example, like amitriptyline. Those are preferred as the first-line drugs. Serotonin and norepinephrine reuptake inhibitors like duloxetine or milnacipran, these are, and as well as pregabalin, are alternate therapies that can be useful in patients who don't respond to the TCAs. So TCAs is always the one that they like to ask for fibromyalgia. If the TCA doesn't work, and if that's a question, they're on like a TCA, like amitriptyline, it's not really working, what would you like to switch them over to? Then you can do like a duloxetine or a pregabalin. Patients with persistent symptoms can or may require combination drug therapy, also referral for supervised rehabilitation, pain management consultation, or cognitive behavioral therapy. Okay, so that was it for fibromyalgia. Now we're moving on into polymyositis. So polymyositis, how does it clinically present? It's with symmetrical proximal muscle weakness, and there's no mild pain, or there could be no pain or there could be mild pain. Sorry. Either they have mild pain or no pain, or muscle tenderness. The diagnostic test for polymyositis would be an elevated muscle enzyme like CK or aldolase, autoantibodies, so like ANA or anti-Jo1. I like to ask that anti-Jo1, and biopsy, so endomesial mononuclear infiltrate, as well as patchy necrosis would be seen on biopsy. And biopsy, remember, for most answer choices, it's always going to be the definitive diagnosis. So the mononuclear infiltrate surrounding necrotic and regenerating muscle fibers, that's the definitive diagnosis for polymyositis. Some associated conditions are going to be like interstitial lung disease, myocarditis, but they like to ask about malignancy. So you want to carefully examine these patients, especially age-appropriate screening. Treatment for polymyositis would be systemic steroids, and there can also be a steroid-sparing agent, so you can also give them like methotrexate or azathioprine. Okay, and then for polymyositis, it's an inflammatory disease of the muscle. It's slowly progressive, proximal muscle weakness of the lower extremities. So they have difficulty negotiating the stairs. So it's like they're looking at the stair and they're just wondering if if they're going to be balanced or not, if they can actually do it. Or rising from a seated position is going to be difficult. Proximal arm weakness is going to follow. Then they'll also present with difficulty working with their arms overhead. So it maybe they'll trip you up and give you difficulty combing their hair and climbing stairs. So that's another one for polymyositis. It can also develop dysphagia due to the involvement of the striated muscles that are in the upper pharynx. So dysphagia can be another associated presentation, as well as mild pain or tenderness can also be present, but severe pain or lack of muscle weakness should prompt other types of diagnosis. So if they're in real severe pain, it's probably not polymyositis. Okay, so here, and there's a graph on UWorld that's excellent that talks about the differential diagnoses of neuromuscular weaknesses, and it shows the anterior horn cells, the upper motor neurons, right? It shows you a picture of the nerve and then the neuromuscular junction. And then it tells you in different points what diseases are associated with each and every one of those locations. So for instance, this is a really good one, so I'm just going to briefly explain it. The anterior horn cells of the spinal column, the diseases associated with the anterior horn cells would be like spinal muscular atrophy, amyotrophic lateral sclerosis, ALS, paraneoplastic syndromes, and polymyositis. I'm sorry, not polymyositis, polymyelitis. I was wondering, that doesn't make any sense. Poliomyelitis, all right, so polio. These are all in the anterior horn cells. Now, the upper motor neurons, here the diseases associated with upper motor neurons are going to be like leukodystrophies, vasculitises, a brain mass can also cause a problem with the upper motor neurons, and vitamin B12 deficiency with that subacute combined degeneration of the whatever, I can't remember, of the cortical tracts or whatever. Then we have peripheral nerves. Some of the diseases that affect the peripheral nerves are hereditary primary motor sensory neuropathies. You have Guillain-Barré syndrome, diabetic neuropathies, as well as amyloid neuropathy, such as myelomas, for instance, and lead poisoning these all affects the peripheral nerves. And then at the neuromuscular junction, we have myasthenia gravis, we have Lambert-Eaton syndrome, organophosphate poisoning, and botulism. And then finally, in the muscle fibers themselves, here we have your polymyositis, dermatomyositis, as well as your muscular dystrophies. Hypothyroidism can also affect here. Steroids directly affect the muscle fibers, as well as HIV myopathy. So electromyography, this is used for differentiating polymyositis from other causes of weakness, but it's nonspecific. It's just going to tell you that there's problems here with the muscle. Okay, so we talked about polymyositis. Now we're going to talk about dermatomyositis. So what is dermatomyositis? The same thing, but with a rash, right? Just kidding. Or maybe not. So clinical features of dermatomyositis would be muscular weakness, such as proximal muscle weakness or symmetric muscle weakness. And the weaknesses here are the same in the upper and the lower extremities. Okay, and then on the skin, you'll see a rash, and that's your heliotropic rash, as well as more specifically Gotrin's papules, and those are pathognomonic for this disease. It's an eruption on the chest and lateral neck, also known as a Schall sign, is also seen with dermatomyositis. So the Schall sign, the Gotrin's papules, and a heliotropic rash. Okay, then we have the extramuscular findings like interstitial lung disease, also dysphagia and myocarditis, because all these are surrounded by muscle, and that can be involved, causing you those problems. Diagnosis is based on an increase in CPK. Usually that's 10 times the upper limit of normal. And that increase in CPK can also lead to myoglobin-induced acute kidney injury, obviously because of the myoglobin damaging the tubular cells. Also, aldolase can go up, as well as lactate dehydrogenase. There's also an anti-RMP, anti-Jo1, and anti-MI2 associated with dermatomyositis. So the anti-Jo1, remember that was dermatomyositis and polymyositis. And then diagnostic uncertainty, if you're still not certain, you can do an EMG and obviously a biopsy of the skin and the muscle. And the management would be high-dose steroids with a glucocorticoid sparing agent like methotrexate, for instance. And then screening for malignancy is also done at regular age-appropriate screenings. So dermatomyositis is 6 times more common in females. So if you're going to get a question, it's going to be a female patient. The anti-Jo1 is an anti-synthetase antibody, and the anti-MI2 is an antibody against helicase. Okay, so MI2, think of James Bond as an MI6, right? So MI2 and helicopters, I don't know, against helicase. So 15% will have or will develop internal malignancies, and most commonly those malignancies would be like ovarian, pancreatic, lung cancer, stomach cancer, or colorectal cancer, as well as non-Hodgkin's lymphoma. For polymyalgia rheumatica, so here the symptoms for polymyalgia rheumatica is ages greater than 50. Also with bilateral pain and morning stiffness, and that lasts for more than 1 month. It's going to involve 2 of the following groups. So the neck or the torso, the shoulders or the proximal arms, as well as the proximal thigh or hip. And it can also have constitutional symptoms such as fever, malaise, and weight loss. On physical examination, there's going to be a decrease in active range of motion, specifically in the shoulders, as well as the neck and in the hips. And on lab studies, the ESR is going to be increased more than 40 millimeters, and sometimes even more than 100. There's going to be also a elevated C-reactive peptide and a normocytic anemia possibly. There's going to be around a 20% chance of having normal studies, however. So the lab studies may be normal in these patients. The treatment is they respond to steroids. So it's rapid, and if it doesn't improve, then you need to question whether the diagnosis was even the right one. So steroids. Physical examination is frequently unremarkable with patients having no focal tenderness or pain with active or passive range of motion. So it's kind of hard to make a diagnosis if they're not having any symptoms at the moment. Also, patients have objectively normal muscle strength in polymyalgia rheumatica. There's negative signs of inflammation, so it's all pretty much a normal picture, right? And when asked to identify the location of the pain, patients typically indicate soft tissues and not really the joints. So it's a kind of hard one to diagnose, really. Next up, we have Charcot joints, and this is a neurogenic arthropathy. It has some associated conditions such as vitamin B12 deficiency, diabetes, peripheral nerve damage, spinal cord injury, syringomyelia, and tabes dorsalis, or a tertiary syphilis, are all associated with a Charcot joint. Clinical manifestations would be a deformed joint that lacks a decreased sensation, so proprioception, pain, or temperature is going to be decreased, with loss of neurological input. Also, there can be arthritis or arthropathy, mild pain. Fractures may be unsuspected by the patient, especially if they have a neuropathy, and degenerative joint disease and loose bodies on joint imaging. And the degenerative joint disease is osteophytes and loss of cartilage. And how would you manage is you want to treat the underlying condition causing the Charcot joint, mechanical devices that can assist in weight bearing or decrease further trauma. So the mechanical devices would be a good treatment option. Also, x-rays, obviously, if the trauma is present. So a Charcot joint is just basically a joint that it's a loss of neurological input. So there's no sensation there. There's loss of pain, there's loss of temperature, loss of proprioception, and there's going to be, and because of this, there can be repetitive trauma due to weight on the weight-bearing joints, right? And this is causing a secondary degenerative joint disease. It can cause even joint deformation because you're not feeling anything. How do you know if anything is wrong if you're not feeling anything? Normally, pain, sometimes people perceive pain as a bad thing. If you think about it, pain is a good thing because it's telling you that something is wrong. So if something is wrong, you tend to adjust yourself so that you have no more pain. But in these patients, something could be wrong, but they're not perceiving pain because there's no neurological input there. So that can cause a deformation of whatever is causing or where the pain is located, as well as functional limitation. And x-rays will show loose bodies. It can show osteophytes as well as loss of cartilage. And in diabetes, there can also be a vasculopathy that can contribute to the disease. So not only do you have disease because of neurological loss of pain, but also because of vasculopathies, which sometimes goes hand in hand, right? All right. Next up, we have gout. So hopefully we don't have gout because that's painful and it sucks. But anyway, gout, causes of gout would be either due to two things that we learned in step 1. We have either increased production of urate or a decreased clearance of urate, right? So what was the increased urate production? That's primary gout. It's idiopathic. It's seen with myeloproliferative lymphoproliferative disorders. It's also seen with tumor lysis syndrome and when there's a enzyme deficiency, such as the hypoxanthine guanine phosphoribosyl transferase deficiency. That's if there's an increase in urate production, too much urate. Now, if you have a decrease in urate clearance, obviously you're not eliminating it from the body. And this, you can just go straight to the problems in the kidneys, as well as thiazide or loop diuretics. All right, so risk factors for gout. So increased risk factors would be like medications such as diuretics, like we just mentioned, loop or thiazide diuretics, low dose aspirin as well, surgery, trauma, and recent hospitalization. Volume depletion can also be a risk factor because that can cause renal problems, causing there to be a decrease in clearance of urate. Diet, a high protein diet, such as high consumption of meat or seafood, high fat diet, fructose or sweetened beverages. Heavy alcohol consumption as well can cause gout. And underlying medical conditions such as hypertension, obesity, chronic kidney disease, obviously, and organ transplant. Now, decreased risk factors would be dairy product intake, vitamin C that exceeds more than 1,500 milligrams a day, and coffee, apparently. These are decreased risk factors for gout. So have your cup of coffee. Acute flares of gout is an abrupt onset with maximal symptoms that happen within 12 to 24 hours. If the gradual onset is in more time, then the joint aspiration for cell count, gram stain, and culture is all going to be done to check for septic arthritis. Otherwise, a typical gout flare typically is treated either by the presence of crystals and will not rule out specific types of arthritis, as well as these will be present between attacks. So in septic arthritis, the cell count is going to be greater than 50,000 and you're going to have a positive gram stain. So you want to start empiric antibiotic treatment until the culture results are known. If it's gram positive, right? Up to 50,000 cells with negatively birefringent needle-shaped crystals can be seen. An X-ray is in chronic gout will show punched out erosions with an overhanging rim of cortical bone, and that's called as a rat bite lesion. So I don't think I've ever seen that on a test, but there you go. Then you have urate lowering medications. These are not given after the first attack. Remember that the first attack you want to give like colchicine or NSAIDs. These are given in recurrent attacks and complicated diseases where tophi are involved or renal, uric, and acid stones are involved. That's when you do the urate lowering medications. Allopurinol specifically is going to inhibit uric acid production, and that's used for prevention. It's not used for acute treatment. It's used for prevention in patients with hyperuricemia due to due to gout, right? Then you have NSAIDs, steroids, and colchicine. These are given in an acute attack. These, as well as short-term steroids, can also be given in patients that are started on urate-lowering medications, just so they can prevent flare-ups, right? So, if the patient has been started on allopurinol because they want to prevent gout attacks, you also want to kind of maybe consider giving steroids just in case they might have a gout attack in the process of trying to be trying to have preventive measures. So just for those flare-ups. Steroids are relatively contraindicated in diabetes, however. And the prevention of future gouty attacks, obviously you want to ask the patient to lose weight, have a low-fat diet. Their BMI should be less than around 25. Decrease seafood and red meat intake. Protein intake is preferably from vegetables and low-fat dairy products instead of from fats and red meats. You want to avoid organ-rich foods like liver and sweetbreads. And also avoid beer as well as distilled spirits, and avoid any type of diuretic whenever possible. Avoid foods that contain fructose and other refined sugars. Sounds like a health plan, obviously, almost. Obesity, hypertension, aspirin, beta blockers, diuretics, and diabetes. These are all risk factors for recurrent gouty attacks. Smoking and an increase in coffee intake, however, decreases the risk of gout, probably due to the vasoconstrictive effects of these. I'm not condoning smoking, but don't mind a nice cup of coffee for every once in a while. All right, next up we have pseudogout. Now, pseudogout, or acute calcium pyrophosphate crystal arthritis, these present as an acute monoalveolar or oligoarticular arthritis. It's also seen in the peripheral joints, the knee being the most common area. But it can occur in multiple joints. And the age of onset is usually more than 65 years old with the pseudogout. The diagnosis is going to be an inflammatory effusion. So there's going to be around 15 to 30,000 cells. Calcium pyrophosphate dehydrogenate crystals. So you'll see those rhomboid-shaped positively birefringence. Way that I remember is pseudogout starts with a P, positive birefringence starts with a P, so that's a good one. And chondrocalcinosis on imaging. They also like to trip you up sometimes. It's gotten me 2 or 3 times in the past when they tell you positively birefringence, but then when they show you a image of the crystal, it's like they'll have like negative birefringence in the image, but it'll look negative, but it's really positive. Remember, we're not pathologists, and if that's what you want to do, you're not a pathologist yet. You're still taking your exam, so look for what they're asking you in the question, not what you see on a slide. So if you see like needle-shaped negatively birefringent crystals that you think are those things, but in the vignette it's telling you that it's a positively birefringent rhomboid shape, pick pseudogout, because they do like to trip you up on that sometimes. Also, chondrocalcinosis on imaging is seen. And the treatment for pseudogout is going to be intra-articular glucocorticoids, as well as NSAIDs and colchicine. Remember that pseudogout is common in hypoparathyroidism, as well as in chronic hypercalcemia, hypothyroidism, and in hemochromatosis. Pseudogout, if there's pseudogout, you'd also want to look for other causes. So just remember that's common in all those things. Acute attacks occur in the setting of traumas or overuse injuries, surgical or medical illnesses, and it can also cause chronic inflammatory arthritis resembling rheumatoid arthritis and non-inflammatory degenerative arthritis that can resemble osteoarthritis. On X-ray, it's useful for diagnosing it if they have chondrocalcinosis. That's a good one. You see those little very hyperdense images on the x-ray. That's an indicator of calcium pyrophosphate, calcium crystal deposition. And yeah, so that's it for pseudo-gout. Next up, we have hereditary hemochromatosis. So for hereditary hemochromatosis, some of the clinical manifestations would be found in like the skin, the musculoskeletal, the GI, endocrine, cardiac, as well as infections that can clinically have a clinical manifestations of hereditary hemochromatosis. So for the skin, you'll see hyperpigmentation or bronze diabetes. For musculoskeletal, you'll have arthralgias, arthropathy, and chondrocalcinosis. In the GI, there can be elevated hepatic enzymes with hepatomegaly early on and cirrhosis later on, with an increased risk for hepatocellular carcinoma. So that's that increased risk for hepatocellular carcinoma is important association for hereditary hemochromatosis. Endocrine, obviously type 2 diabetes, mellitus, secondary hypogonadism, as well as hypothyroidism. And for cardiac causes of hemochromatosis, you have restrictive or dilated cardiomyopathies. It's associated also with conduction abnormalities. And some of the infections would be an increased susceptibility to Listeria infections, Vibrio vulnificus, and Yersinia enterocolitica. So you diagnose this with serum iron studies, right? Hemochromatosis, heme iron studies. And this it's confirmed with genetic testing. And liver biopsy is generally not done, but it could be done to stage liver disease, or if you need to confirm a diagnosis if the iron studies itself weren't suggestive and the genetics weren't positive. That's the only case you do a liver biopsy. Other than that, genetic testing is the test of choice to confirm. Treatment would be serial phlebotomies and depletion of serum iron stores. Next up, we have secondary amyloidosis. Some of the clinical features would be an extracellular deposition of insoluble polymeric protein fibrils in tissues and in organs with an elevated amyloid A. It could be secondary to chronic inflammatory conditions like inflammatory arthritis, such as rheumatoid arthritis, also chronic infections like bronchiectasis, TB, and osteomyelitis. Also, inflammatory bowel disease, such as Crohn's disease. Malignancies like lymphoma and vasculitis are all epidemiologies of secondary amyloidosis. Clinically, they're going to present asymptomatically with proteinuria and or nephrotic syndrome. There can be cardiomyopathy with heart failure, hepatomegaly. There can also be a mixed sensory and motor peripheral neuropathy or autonomic neuropathies, as well as visible organ enlargements like macroglossia, for instance. There's also bleeding diatheses and waxy thickening and easy bruising of the skin. The diagnosis is made with abdominal fat pad aspiration biopsies, and you really want to treat these patients by treating the underlying condition. Colchicine is used for prevention as well as for treatment. And that's all I had to say about amyloidosis. Sound like Forrest Gump. Anyway, autoimmune hepatitis, we have anti-smooth muscle antibodies towards autoimmune hepatitis. There's a variety of liver diseases, asymptomatic, mildly elevated aminotransferases, and acute liver failure, as well as cirrhosis. It's associated with type 1 diabetes, not type 2, for autoimmune, for obvious reasons. And joint complications are less common in autoimmune hepatitis, and they can cause arthralgias of the small joints. So that's it for autoimmune hepatitis. Whipple's disease, this is another easy one. This is a multi-system disease characterized by multiple possible manifestations. So signs and symptoms would be a history of chronic malabsorptive diarrhea or steatorrhea. There can be flatulence, abdominal distension, and it's basically a protein-losing enteropathy with weight loss, migratory non-deforming arthritis, as well as lymphadenopathy and a low-grade fever. This can damage the eye and the CNS as well as the myocardium. It's caused by an infection with the gram-positive bacillus called T. whippleyi, trophiremia, I think it's called, trophirema whippleyi. It's also, the mechanism is unknown on how they get it transmitted. And the diagnosis is made with a small intestinal biopsy and PCR in a patient with clinical symptoms consistent with the disease. But most importantly is going to be the biopsy, where you see PAS positive macrophages in the lamina propria containing non-acid fast gram-positive bacillus. So that PAS positive with Whipple's disease is very, very important. Pathognomonic. All right, next up we have Paget's disease of the bone. So in Paget's disease of the bone, clinical features is that most patients are going to be asymptomatic. There's going to be bone pain with deformities in the skull. They can have headaches, hearing loss with frontal bossing, as well as cranial nerve dysfunction in Paget's disease. The spine can have spinal stenosis or radiculopathies, and the long bones are going to show bowing. Also, there are increased risk for fractures, as well as arthritis of especially the pelvis and the clavicle, and the adjacent joints in long bones. Also, clinical features would be a giant cell tumor and an osteosarcoma with Paget's disease. The pathogenesis of Paget's is an osteoclastic dysfunction with an increase in bone turnover. So I think step 1 asked that. It's an osteoclast dysfunction. For lab testing, there's going to be an elevated in alk phos because of that bone turnover. Elevated bone turnovers markers like PINP, not PIMP, like 50 Cent. This is PINP, which is a procollagen type 1N peptide. Urine hydroxyproline as well. Those are your bone turnover markers. Imaging is on X-ray. You'll see osteolytic or mixed lytic sclerotic lesions showing cortical thickening. And on bone scan, there's going to be focal increases in uptake. The treatment for Paget's is going to be bisphosphonates, and those are going to inhibit osteoclast function and decrease bone turnover. It's also why it's good for osteoporosis as well. For alkaline phosphatase, remember this is a ubiquitous enzyme that has the highest expression in bone and hepatobiliary tissue. It's a useful marker of cholestatic liver disease, not hepatocellular, in which there is elevation of transaminases. And this disease of the bone causes increased bone turnover, right? So most common cause of isolated asymptomatic elevation of alk phos in an elderly patient is going to be Paget's disease of the bone. Remember, osteitis deformans is another way of saying Paget's disease of the bone. Osteitis deformans, and that's the most common cause of isolated asymptomatic elevation of alk phos in an elderly patient, because that's the way they're going to present it in the vignette. Maybe like 88-year-old patient comes in for his regularly scheduling programming visit, and suddenly you notice the alk phosphatase levels extremely high. And then blah, 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 what is it? Osteitis deformans or whatnot. Most commonly, it's found incidentally, like we just said, discovered on routine blood tests. Alk phosphatase levels can be strikingly elevated, often more than 10 times the upper limit of normal. And fractionation of alkaline phosphatase is going to lead to a predominance of bone rather than liver isoenzymes. Patients are going to be asymptomatic with minimal disease activity, with incidental discovery of mildly elevated alkaline phosphatase, and may be left untreated and observed. Symptomatic patients and those with high-risk bone involvement, like skull and weight-bearing long bones, should be treated to decrease the pain and to decrease the risk of complications. So again, Paget's disease of the bone. There's a really good image on UWorld. It shows like a femur, and then it shows different stages of the Paget's disease, or different levels within the bone and where it's being affected. So you have your osteolytic phase, which is your osteoclast dominant phase. Then you have your mixed phase, where you have osteoclasts with osteoblasts, so they're kind of doing the whole new bone formation while it's being eroded at the same time. And then you have your osteosclerotic phase, which is just osteoblast dominant, but then you're going to have weakened, thickened woven bone. And that's it for Paget's disease. Next up is your osteitis fibrosa cystica, which is also known as von Recklinghausen disease of the bone. This is when patients present with bone pain characterized by excessive osteoclastic resorption of the bone that leads to then replacement of the fibrous tissue known as brown tumors. It's very rare, and it's seen primarily in patients with parathyroid carcinoma. And it can also occur in primary and in secondary or tertiary hyperparathyroidism, which is seen in advanced renal disease. So just remember the brown tumors, advanced renal disease with hyperparathyroidism. That's a osteitis fibrosa cystica, known as von Recklinghausen disease. And then finally we have infectious arthritis. Within this, we have your viral arthritis, and that can present similar to rheumatoid arthritis, and also ANA. So this could also be ANA sensitive for lupus, but it may be positive in rheumatoid arthritis, HIV, hepatitis, and normal individuals. It can also be positive. So ANA can also be positive. RF positivity can also be seen. So it's all similar to rheumatoid arthritis when you have a viral arthritis. They're going to present with symmetric inflammatory arthritis that resolves within 2 months. If that's so, it's just viral arthritis. And the causative organisms obviously are going to be your viruses, your parvovirus specifically. Also hepatitis can do it, HIV, although HIV can lead to obvious more serious complications than a little arthritis here, but HIV is a viral cause, mumps and rubella among many others. And the treatment for viral arthritis is just NSAIDs for the symptoms, and it just goes away by 2 months. So yeah, that's infectious arthritis. Next up, we're going to talk about Lyme disease. All right, so for Lyme disease, it's going to be divided into stages. So you have early localized stage, you have an early disseminated stage, and you have a late or a chronic stage. For the early localized stage, this happens within days to 1 month, and that's after the tick bite. Clinical manifestations at that stage would be your erythema migrans, which is seen in about 80% of patients. There's also fatigue, malaise, and lethargy. Also mild headaches and neck stiffness with myalgias and arthralgias. So that erythema migrans is the most important one, within a day to a month. Now you have early disseminated, which is after the tick bite, which is weeks to months. And that's where you have your carditis, which is seen in 5% of patients who are untreated. And that carditis can lead to an AV block or a cardiomyopathy. Neurologic causes as well. In 15% of untreated patients, here you'll have your unilateral or bilateral cranial nerve defects. Usually it's cranial nerve 7, as well as meningitis and encephalitis. So those neurological signs are seen in this stage. Muscular signs are seen in 60% of untreated patients. So this is by far the most common on this stage. And here you have your migratory arthralgias. These can be either monoarticular or it could be oligoarticular. And most commonly, it's involved within the knee. The synovial fluid is going to show inflammatory profiles, so like a leukocyte count of around 25,000, right? And the diagnosis of Lyme arthritis is going to be confirmed with an ELISA and a Western blot. And the treatment for Lyme disease, you guessed it, it's oral doxycycline, or it's amoxicillin if they're maybe they're younger than 8 years old for Lyme disease. Another early disseminated manifestation is conjunctivitis. This is seen in 10% of untreated patients. And then finally, in your skin, you can also have multiple erythema migrans seen in early localized, like we said. And it could be, you can have either generalized or regional lymphadenopathy as well. So the most common and early disseminated is going to be the muscular migratory arthralgias, carditis, and neurological causes. For late onset or late stage chronic Lyme, which happens months to years after the tick bite, here again, muscular causes again is the most common cause in untreated patients. There you have your arthritis, and neurological, you'll have encephalomyelitis or peripheral neuropathy. Okay, so it's most prevalent, Lyme disease is most prevalent in the northeastern and upper Midwest states of the United States, places where it's cold and foresty, where there's a lot of deers, right? That's where it's most prevalent. Next up is osteomyelitis, and this causes fever, malaise, and localized joint pain and swelling, which really doesn't tell you much. So chronic osteomyelitis will show central lytic bone defects with surrounding sclerosis, and that's termed Brodie's abscesses with osteomyelitis. This is just something I wanted to throw in there. For gonococcal arthritis, this is due to a disseminated gonococcal infection. So clinically, they're going to present with purulent arthritis without skin lesions, or they can have a triad of either tenosynovitis, so that affects like the wrist, the ankles, fingers and knees, all those little joints, dermatitis with pustules, macules, papules, or bullae, or you can have migratory asymmetric polyarthralgias without purulent arthritis. The diagnosis for gonococcal arthritis is done with blood cultures. You're going to have 2 sets of blood cultures, but again, these could be negative. The synovial fluid analysis can show up to 50,000 cells in the synovium. Also, you can have urethral, cervical, pharyngeal, or rectal cultures done, specifically with a nucleic acid amplification test with the culture. Also, you'd want to do a HIV and syphilis screen when you're thinking gonococcal arthritis, obviously because it's mostly sexually transmitted. Recurrent disseminated gonococcal infections, you're going to want to check terminal complement activities as well. For treatment, gonococcal arthritis is treated with IV ceftriaxone 1 gram per day for 7 to 14 days. And then you want to switch to oral cefiximine when they clinically improve. It's obvious that way because you're in the hospital, you have to be given IV medication. Once they start feeling better, you can switch them over to an oral medication. We'll see later on step 3. But here's step 2, CK. So now you have joint drainage for purulent arthritis as well. You're going to want to drain that joint. And empiric azithromycin is given as a single gram dose, or you can give doxycycline for 7 days if you also have a concomitant chlamydial infection. And also you want to treat the sexual partners as well. So septic arthritis in sexually active young adults is going to be gonococcal arthritis until proven otherwise. The gram stain of the synovium is going to be positive in about 25% of cases. Blood cultures are going to be positive in 20 to 50% of cases. And genital and pharyngeal nucleic acid amplification tests are going to be positive in about 90% of cases. And that's usually used to confirm the diagnosis, the nucleic acid amplification test. Next up, we have arteritis. And it's always a fun word to say, arteritis. So you have giant cell arteritis being the most common arteritis. And here you'll have symptoms of fever, fatigue, malaise, weight loss. There's localized symptoms such as headaches located specifically around the temporal areas with jaw claudication. And that's the most specific symptom of giant cell arteritis. Also, polymyalgia rheumatica has giant cell arteritis. Arm claudication, it's associated with bruits in the subclavian or the axillary areas. And these would be diminished pulses or bruits over the axilla, the brachial, or the femoral arteries, and as well over the supraclavicular and or the carotid artery areas. There can also be aortic wall thickening or aneurysms, so you're going to want to follow up by doing serial chest x-rays. And then in the CNS, there's also signs of TIAs or strokes, vertigo, and hearing loss as well with giant cell arteritis. Visual symptoms would be your amaurosis fuga, which is a transient vision field defect that progresses to a monocular blindness. And then you have your AION, which is an anterior ischemic optic neuropathy. That's what AION stands for. That's the most common ocular manifestation. So in these cases, you want to do a fundoscopy where you see a swollen and pale disc with blurred margins. That's an anterior ischemic optic neuropathy with giant cell arteritis. On lab results, you'll see a normal chromic anemia with elevated ESR and C-reactive protein, and you're going to want to do that temporal artery biopsy. And the treatment is for if they have PMR or polymyalgia rheumatica, you want to give them low-dose oral steroids, like we said, for the polymyalgia rheumatica, prednisone 10 to 20 milligrams a day. For giant cell arteritis, intermediate to high-dose oral steroids, like prednisone 50 to 60 milligrams a day. And if they have giant cell arteritis with a visual loss, then you want to do pulsatile at high dose IV steroids, specifically methylprednisolone 1,000 milligrams a day for 3 days, followed by intermediate to high dose oral steroids. And you'd want to slowly taper them off of that over the next several months, because those are way high levels of glucocorticoids. All right, next arteritis is going to be Takayasu's. So we already mentioned giant cell arteritis, so now we have Takayasu's arteritis. Here, you're obviously going to have an Asian. Sorry, the Takayasu sounds Asian. So it's a female Asian between the ages of 10 to 40. The symptoms are constitutional fever and weight loss with arterial occlusive symptoms in the upper extremities. So what do I mean by that? Arterial occlusive meaning claudication or ulcers in the upper extremities. Also, they can have arthralgias and myalgias. Takayasu's arteritis is they're gonna have blood pressure discrepancies, pulse defects, pulse deficits, and arterial bruits. And the diagnosis is done with an elevated inflammatory marker such as your ESR or your CRP. And the chest x-ray is going to show aortic dilation with a widened mediastinum. CT or MRI is going to show wall thickening and a narrowing of the lumen. And the treatment here for Takayasu's is going to be systemic steroids. Mononuclear infiltrates and granulomatous inflammations of the vascular media is going to lead to arterial wall thickening with aneurysmal dilations and narrowing, as well as occlusion. So initially, non-specific symptoms occur, and later you get your arterial occlusive symptoms that develop. And patients commonly have anemia with Takayasu's. Next up, we're going to talk about the vascular tumors. Some of the vascular tumors include the glomus tumor, which is a common benign vascular tumor, which presents as a triad of severe intermittent pain, tenderness, and sensitivity to touch. There's also subungual in 70% of cases, and other sites of the palm or the wrist are seen with these glomus tumors, subungual. And it's common in the 4th decade of life. And for glomus tumors, it's more common in females than in males. For bone tumors, one of the most common ones here are your osteoid osteitis, followed by osteosarcoma, Ewing's sarcoma. You have your chondrosarcoma, fibrosarcoma, giant cell tumor of the bone, and we'll get to all those in a second. So starting with osteoid osteoma. This is a benign bone-forming tumor, and it's common in adolescence and in early adulthood, especially in males. It most commonly affects the proximal femur, and it could also involve other long bones, and it can even involve the spine. And the symptoms present with increasing pain that gets worse at night. There's no association with physical activity, and the pain is relieved with NSAIDs. And that strongly suggests that diagnosis. On physical exam, children will have focal tenderness, swelling, or deformities, versus adolescents often don't have any kind of focal neurological finding, or focal findings, sorry. X-ray is going to show a typical small round lucency with sclerotic margins, and sometimes you have a central ossification. The treatment for an osteoid osteoma is going to be NSAIDs for symptomatic relief, as well as serial examinations and X-rays done every 4 to 5 months to monitor the lesion. A surgical resection is going to be reserved for those patients that are refractory to symptoms. And most lesions are going to resolve spontaneously, and it takes about several years to get better. So you just treat symptomatically with NSAIDs. And it's a benign forming tumor, it goes away on its own. So if you are presented a case with osteoid osteoma, it's most likely going to be a child, because they're going to complain of focal tenderness, swelling, and deformities, versus an adolescent. It's just going to, no focal findings are going to be seen on exam. So it's easier to test in a child. So they'll present you with a child, and that's your osteoid osteoma. Sometimes they'll give you an X-ray. You don't even have to read the vignette, because it's going to show a little small round lucency. It's like a little dot there, and you're, okay, this is osteoid osteoma. Boom, you're done. Hopefully. Okay, now osteosarcoma, this is the most common primary tumor that affects children and young adults. Boys, they start around 13 to 15 years old, are at higher risk. So you're going to see 13 to 16-year-old boy as the most common primary tumor. Locations is going to be frequently occurs in the metaphysis of the long bones, such as your distal femur or proximal tibia, or it can even be the proximal humerus. And the signs and symptoms for an osteosarcoma are chronic localized pain with constitutional symptoms like weight loss, fever, malaise, which is usually, but those are usually absent. So on physical exam, you'll have a palpable tender soft tissue mass, and on X-ray they'll show destruction of normal bone patterns with indistinct margins and a mixture of radiodense and radiolucent areas. And it's characteristic of a spiculated or a sunburst pattern. And you have your periosteal elevations, and that's known as your Codman's triangle. It's like a little flap of bone that's trying to escape the surface of the bone. So that's osteosarcoma. Or you can have, or on the surface, you're just going to look like, it's going to look like a sun rising from the horizon kind of look. Again, if you see an X-ray of it, you don't need to even read the question. It's osteosarcoma, you're done. The labs are going to be an increase in alk phosphatase. There's also going to be an increase in lactate dehydrogenase, and that's due to turnover of the bone, and that turnover is caused by causes damaged osteocytes. High levels will cause a worse prognosis, and an increase in ESR is going to be seen. But remember, ESR, C-reactive proteins, those aren't very specific markers. They just tells you that there's an inflammation going on. And the treatment is going to be tumor excision as well as chemotherapy. All right, so the next tumor is going to be your Ewing sarcoma. And for a Ewing sarcoma, this is a highly malignant tumor, causes early metastasis to the lungs and to the lymph nodes. So this is a big one. It affects the long bones of the extremities, the lower limbs more than the upper limbs, and it's most commonly seen as well in the metaphysis and the diaphysis of the femur, followed by the tibia and the humerus. So the lung bones, right? And it's usually seen in white males in their first or second decade of life. So this is an adolescent male. But second most common primary bone tumor. Well, it's not an adolescent male, really, but males in the first, second decade of life. Signs and symptoms would be like pain and swelling for many weeks to months, and deformities, erythema, and there's going to be warmth of the area, localized area. That's sometimes seen. A misdiagnosed initially as an osteomyelitis because they get fever, leukocytosis, anemia, an increase in ESR, and an adolescent with bone pain. You're thinking it might be osteomyelitis. It could be a cause of extensive involvement of the affected bone, and systemic symptoms in 20% of patients can occur. Now, you can demonstrate multiple layers of new subperiosteal bone formation. Because of that, those multiple layers look like an onion. So on radiographs, you have a lamellated appearance or an onion skin, periosteal reaction. And it's usually a lytic reaction, central, and it's accompanied by endosteal scalloping, followed by a moth-eaten or a mottled appearance, and it can go and extend itself into the soft tissue. So that's the big one. Also, is another X-ray finding is you're going to see your onion skinning. It's going to look like an onion sliced in half. On radiation, treatment is radiation, also surgery and multi-drug chemotherapy, because remember, these are highly metastatic tumors. Radiation and chemotherapy is used preoperatively. So that was Ewing sarcoma. Chondrosarcoma, this often occurs in the 5th or 6th decade of life. People with multiple endochondromas and hemangiomas are at higher risk than the general population. So they'll give you a patient with previous history of either a hemangioma, probably like in the liver or something, or an endochondroma, probably a hemangioma. Because other than that, the X-ray is going to show fusiform defects with scalloping, and that's your chondrosarcoma. Just think of older person with a hemangioma comes in with like a bone tumor. There you go, chondrosarcoma. For fibrosarcoma, this is a malignant spindle cell neoplasm that's seen in 30 to 60-year-olds. Clinical picture is just a painful mass, and on X-ray you'll see an osteolytic lesion whose margins are well defined, or they're also ragged or moth-eaten. So it kind of sounds like Ewing sarcoma, but this obviously in a much older population, 30 to 60-year-olds, whereas Ewing's is in the first and second decades. So then that was fibrosarcoma, and then you have a giant cell tumor of the bone. This is a benign and locally aggressive tumor seen in young adults. Signs and symptoms are pain, swelling with a decreased range of motion around that affected joint because of all that pain and swelling. 10 to 35% of patients are going to experience pathological fractures. That's due to the bone cortex being too thin in the weight-bearing areas. An X-ray is typically going to be present, on X-ray, you're going to typically see epiphyseal regions of long bones, most commonly seen in the distal femur and in the proximal tibia, and it's going to show an expansile or eccentric lytic area. On MRI, it's going to show both hemorrhagic and cystic regions, and on pathology, there's going to be sheets of interspread large osteoclast giant cells that appear as a round to oval polygonal or elongated mononuclear cells. It's simple enough. If you see a pathology slide and you see huge cells and they're pointing in the direction of a bone tumor, that's most likely going to be a giant cell tumor, because none of the other ones have a pathological slide. They're all going to give you an X-ray. They give you a pathological slide. They're pointing into giant cell tumors. And the treatment is surgery. First line is going to be grafting. All right, so screening studies is your next one. And here we're going to talk about osteoporosis screenings, pap smear, colonoscopy, and CTs. So let's start with osteoporosis risk factors. So some of the risk factors for osteoporosis, this is a big topic, and it's a big topic because it's just seen in huge amounts of patients. So you're going to get osteoporosis left and right on this test, just as diabetes, such as hypertension. So in osteoporosis, the risk factors are going to be advanced age, medical history with fractures with minimal trauma, also low body weights, people that are less than 127 pounds, for instance. Family histories of hip fracture for sure. If they're smoking, one of the things you should think of is osteoporosis. Excessive alcohol intake, medications like steroids or anticonvulsants. Secondary causes of osteoporosis, medications, premature menopause, hypogonadism, malabsorption problems like celiac disease because of that vitamin C and vitamin D deficiencies, inflammatory disorders, so inflammatory bowel diseases and rheumatoid arthritis, specifically because they can lead to a malabsorption problem, hyperthyroidism and hyperparathyroidism, Cushing syndrome, specifically because of the steroids that you're taking in Cushing's, vitamin D deficiency because of the malabsorption, and chronic liver disease or renal disease. So anywhere where things have a problem being absorbed, think of diseases, think of medications, think of organ failures that can lead to malabsorption somehow along the line. This will all lead to an osteoporosis risk factor. So what are some of the modifiable risk factors? These are the big ones because these are things that the patient can change on their own. Hormonal factors like low estrogen, you can give them estrogen. Malnutrition like low calcium or low vitamin D intake, obviously give them back the supplements they're missing. Medications like steroids and anticonvulsants can lead to it. So if you modify or adjust the medications, you can prevent osteoporosis. Immobility, so weight-bearing exercise is actually preventive. Cigarette smoking, stop smoking, lowers your risk of osteoporosis. Excess alcohol intake, there's a dose-dependent increase in risk of osteoporosis fractures. Significantly, the higher the risk if you get more than 2 drinks a day. And strict vegan vegetarian diets, because it doesn't contain calcium, in contrast to a lacto-ovo vegetarian diet. Geez, I don't even know what that is, but vegetarian diet's not good. It'll lead to osteoporosis somehow, and it includes foods fortified with calcium such as dairy products, orange juices, cereals, and whole grains. So in those vegetarian diets, which are called the lacto-ovo vegetarian diets, that's okay because you can they are supplemented with calcium, versus strict vegan vegetarian diets. These are frail little people that are going to get osteoporosis later in life if they don't change their diet. Sorry if you're vegan vegetarian, but that's a risk factor. So then you have non-modifiable risk factors. So these are obviously females, the female gender, unfortunately, age, advanced age, someone with a small body size, late menarche and early menopause, also Caucasians, Asian ethnicities, and family history of osteoporosis. These are things you can't change. It's just, it is what it is. I hate that term, but it is what it is. Once upon a time, DEXA screening for osteoporosis was the thing to do. This was seen on all women more than 65 years old and in younger patients who had other risk factors for osteoporosis. The most significant risk factor in the United States is postmenopausal states. So that is the most significant risk factor. The interpretation of a DEXA scan is going to be showing a DEXA scan with a T-scores. So the T-scores are because they still do it, is more than 2.5 standard deviation below the mean. for a young adult at peak bone density causes significant fragility and risks of fracture, where if you have 1 to 2.5 standard deviations below the mean, meaning that you have like a t-score of -1 to -2.5, this will lead to osteopenia, and the results for follow-up of DEXA and screening are not really well established. But still, I mean, there's more specific tests for osteoporosis, but DEXA screening is a good one, and it still is. Pap smear decreases the risk of cervical cancer in young and middle-aged women. The risk of cervical cancer decreases with age. So women greater than 65, or those who have cervixes removed for whatever reason other than cancer, they don't have to ever get a pap smear again. So the thing with the 65 years old is that that's your cutoff if and when throughout your whole entire life, throughout your previous histories of having a pap smear, you never had an atypical pap smear. If you have, and you're over 65, then you kind of still need to get them, unfortunately. But most of the cases you'll see on the vignettes are going to be a patient who's 65 or 66, trip you up like that, really close to the cutoff. But then they'll say they had a normal pap smear 5 years ago. What do you do? Do you give them a pap smear? No, you don't. That's the question. That's the answer, and that's the question. And that did show up on my actual exam, so that's no joke. And then colonoscopy. For colonoscopies, you want to start colonoscopies at 50 years of age in people that have normal risk, and repeat the colonoscopy every 10 years unless there is evidence of polyps. And patients with high-risk polyps, those you're going to want to follow up more consistently every 3 to 5 years. And then you have CT scan of the chest. An X-ray does not decrease mortality in patients with high risks of lung cancer. Low-dose CTs have shown to decrease lung cancer-related mortality in high-risk patients. So, I mean, I've never picked CT of the chest as a type of a screening study, but there you go. Those are the two scenarios, or the scenario there, that it decreases mortality in high-risk patients with lung cancer. Okay, so pharmacology, medications, its uses, and side effects. So some of the things you need to know. So this is the last topic we're going to talk about. So medications such as cisplatin or carboplatin. These are used to treat ovarian and testicular cancer, as well as bladder cancer. Side effects for cisplatin and carboplatin are going to be your cochlear dysfunctions. Also, aminoglycoside medications, which are obviously a antibiotic, is going to cause a cochlear dysfunction. Cyclophosphamide, or cyclophosphamide, sorry, that one causes acute hemorrhagic cystitis, bladder cancer, sterility, and myelosuppression. Remember, again, go back to your UWorld, not UWorld, your first aid, and check out the chemo tox man. Memorize the heck out of that, because it's your friend on the exam. All right, and hydroxychloroquine. This is and ethambutol. So hydroxychloroquine and ethambutol are both associated with optic neuritis. Phenytoin, INH, vincristine, heavy metals, chronic alcoholism, all these are associated with peripheral neuropathies. So just think of all these metals and phenytoin, INH. These will all lead to a peripheral neuropathy. Beta blockers and ergotamine. These cause digital vasospasms, so Raynaud's phenomenon. Amiodarone and lithium will cause thyroid dysfunction, and cyclosporin causes gout. So again, really quick, cisplatin, carboplatin causes cochlear dysfunction as well as aminoglycosides. Cyclophosphamide causes acute hemorrhagic cystitis, bladder cancer, sterility, and myelosuppression. Hydroxychloroquine and ethambutol both cause optic neuritis. Phenytoin, INH, vincristine, all heavy metals, and chronic alcoholism lead to peripheral neuropathy. Beta blockers and ergots lead to digital vasospasms or Raynaud's. amiodarone and lithium cause thyroid dysfunction, and cyclosporin causes gout. And that is going to be the conclusion for rheumatology for internal medicine. I will do a separate video based on what you would see in sports related topics of rheumatology, peds, and I believe that's it. Yeah, so I'll just do a separate video on those two because it's just a little bit more information. Probably it's just going to be maybe an hour long video, but anyway, don't want to keep increasing the length of this one. So anyway, thanks again everyone for participating in this, listening in on my lectures. I really do hope this is a good learning tool for you guys. Again, I wish you all the best on your examinations, and check out my other videos or lectures, and I'll see you guys on the next one. All right, take care.